Good morning and welcome to the Nevada State Board of Pharmacy September 2025 meeting. Today is Thursday, September 4th, and our meeting will now come to order. My name is Helen Park and I'll be the presiding officer. We'll start with the Board of Pharmacy mission statement. In regulating the practice of pharmacy, the Nevada State Board of Pharmacy has a duty to carry out and enforce the provisions of Nevada law, protect the health, safety, and welfare of the public. Next, we'll do our roll call. Mr. Adam Porath.
Here.
Mr. Richard Tomaso.
Here.
Ms. Crystal Freitas.
Here.
Ms. Anna Carr.
Here.
Ms. Jade Jacobo.
Present.
Ms. Shanice Taylor.
Present.
Okay, we have all members present. With that, I'll turn it over to Mr. Weiss for any announcements.
Good morning, Madam President. Standard announcements. The meeting will be held, the Board of Pharmacy meeting today will be held in conformance with open meeting law. Participation will be allowed on Zoom and the public can watch on Zoom. For the public that's in the room, the camera or the TV, said it yesterday too, the TV to the left will provide you a visual of people that are testifying on Zoom. Once again, we've worked with the AG's office. We meet the open meeting requirements, but as an extra courtesy due to the website issues the state's having, we will again post or link into the chat of today's Zoom a copy of both the agenda and the workshop language if anybody wanted to see that at the last minute. And that is in the board meeting room on the cabinet on the right, along with the survey, a copy of the survey from the pharmacist. It might be referenced today or may not be referenced today. With that, Madam President, wish you luck at the meeting.
Great, thank you. So as our first order of business, the board will open up the floor for any public comment. If we have anyone in the room who wishes to make a public comment, please come forward, or if we have anyone online who wishes to make a public comment. And this is for the general public comment. If you have public comment related to a workshop item, we'll take that during the workshop item. Do we have anyone who wishes to make a public comment? You have someone online. Maddie, great.
Hello, this is Leanna Oswald. Just wanted to present that we have the P1 class here, so 48 students present and attending and observing the meeting here from Roseman University College of Pharmacy.
Okay, great. Well, welcome P1 class of Roseman University. Nice to have you here. All right, do we have anyone else who wishes to make a public comment? Do we have anyone online?
No one else online, Madam President, wishing to make public comment at this time.
Great. So we'll close the period for public comment for now. There will be another opportunity at the end of the day as well. So with that, we'll go ahead and move to our agenda items, and we will begin with our workshop item 14B, and I will turn it over to Mr. Weiss.
Thank you again, Madam President. So I'm just going to give a brief overview of how we're here today and what's in front of you. And then Jens going to go through components of the language and make sure that everybody understands that that's on the record. And there's a copy of the language in the electronic board books out there. All right, so in 2022, 2023, through various means, you guys directed the staff to look at safety in pharmacies. Every state at the time was looking at it, and we went out to pharmacies and looked at what was happening in pharmacies. You then, in the beginning of 2024, during this meeting, had directed staff to do and survey all the pharmacists that were licensed in the state, to not licensed in the state, actively practicing in the state, that we could see that were actively practicing in the state or had a license that was located in the state. And so we did that, and we presented that survey in May of 2000, around about May meeting of 2024. The survey's out there, and the board members all have it. If anybody needs one, I have an extra copy here for you. After looking at that survey during a board meeting, you directed staff to write a regulation which we did, and that went to workshop. You received public comment related to it, and made some changes to it, worked with LCB to modify some things such as counseling. Was counseling going to be included or not included? And LCB removed that. And so we got the version back from LCB, and then we were going to do a workshop, or sorry, a hearing on that. That R number is R11324. And we started down the path of having that public hearing. At that time, the governor's office did reach out to us and said, hey, we want to have a couple meetings about that. So we've had those meetings. Both Dick and Helen have participated in those meetings, and then various people from the industry have, and we've worked in the interim to hopefully propose a language that's still built on the survey, but addresses as many concerns as we can related to what industry or individuals brought. And so we've done that. And if there's questions, I don't think I need to go through all of them, but we've addressed everything that we can. And then we have the language in front of you today. And so as we went through the language, we kind of wanted to delineate between different concepts. So the blue language is the language that was in R11324 that staff brought over. I'm sorry.
You said blue, it's the green language. For the staff brought over.
No, green is from the public comment. I got it.
Okay.
The blue language is new language to the law that has been brought over in a different form. And that's what staff has written based off of the survey. The red language is direct language that comes from various different industry people, pharmacy operators, and that's the red language. And then the green language, again, was pointed out, has also been brought over to Yen's point, but that was where we received no public comment on it. So that language, we just wholesale brought over. We did not make changes to it. The blue language we brought over, but we made changes to try to address. And things we heard were hard to count how many prescriptions are doing, hard to staff when you don't know. So we did things like you do it the year before, and then you can do it for the future. There will be more public comment today, and you'll have the opportunity to modify it one more time. I want to remind you that this is a workshop. So this piece of regulation is starting at ground one today. So that is. Our 11324 is still alive. It is alive, and it could go to public hearing if that's a path that you chose to go. I think the intent was to address concerns, provide clarity. I hope that we did that. You can modify it in any way that you want to say. With that, I just want to pause. Did I say that right, Yen?
Yes.
Okay. And then Yen's going to take her time and read certain components. She'll probably talk about the blue, red, and green again, because that has different meanings. I'll say it one more time. Blue is language that is new, but it's based off of our R11324 with modifications to try to address concerns that were brought by stakeholders. The red language is just wholesale from what we heard from other people and what the industry was asking us to put in. It doesn't mean that everybody in the industry wanted that red language. So you might hear testimony today that we didn't want that, but that's just what we kind of got. A lot of what the feedback we got was like Ohio model. You guys, you were there, so you heard. Well, and so we just tried to bring what we could, just so you had a starting point for a palette. And then the green is not language that is approved right now, but it was language that was in the old things that came over. And I think the perfect example of that is an increase in the tech ratio. So nobody was coming in saying they didn't want an increase in the tech ratio. That was found in the survey. So that was in the original document, and that's been brought over and green. With that, I will turn it to Yen.
Yan Long for the record. I'm going to just read certain sections into the record. Can't hear?
I'll give you mine. It's okay. It all will be okay. Helen went really good yesterday. We have plenty of time today.
All right. Can you guys hear me now?
Yes.
All right. All right, section 1, chapter 639 of NAC is hereby amended by adding thereto the provisions set forth as sections 2 through 8 of this regulation. Section 2, 1, except as otherwise provided in subsections 4 and 5, a pharmacy that dispenses controlled substances or dangerous drugs must be staffed with at least 2 pharmacists who are fully dedicated to performing dispensing services 80% of the time of each day the pharmacy is opened to the public, or 65% of the time of each day the pharmacy is open to the public if the pharmacy is open to the public 24 hours a day. And during all other times when only 1 pharmacist is staffed, the pharmacy must be staffed with at least 1 pharmaceutical technician or intern pharmacist fully dedicated to performing dispensing services, or at least 2 pharmaceutical technicians or 2 intern pharmacists, or 1 pharmaceutical technician and 1 intern pharmacist dedicated to performing dispensing services in the pharmacy if the pharmacy also operates as a drive-through window. And if the pharmacy is performing non-dispensing services, the pharmacy must be staffed with an additional pharmacist designated to provide the non-dispensing services. This pharmacist may assist in providing dispensing services, including the dispensing of controlled substances or dangerous drugs, if, in the professional judgment of the pharmacist, patient care and safety are not compromised. The requirements of subsection 1 do not apply on the days the pharmacy fills fewer than 100 prescriptions, which is based on the number of prescriptions filled on the same day in the previous annum. The requirements of subsection 3 do not apply on the days the pharmacy fills fewer than 75 prescriptions, which is based on the number of prescriptions filled on the same day in the previous annum. As used in this section, dispensing services means the filling and dispensing of prescriptions. Non-dispensing services means all activities that a pharmacist performs except for dispensing services. Section 3, in addition to the requirements of section 2, a pharmacy that dispenses controlled substances or dangerous drugs must staff in a manner that meets the demands of the pharmacy and prioritizes patient care and safety. We must staff sufficiently at all times in order to minimize fatigue, distraction, or other conditions which interfere with the pharmacist's ability to practice competently and safely. We must provide sufficient time for pharmacists to complete professional duties and responsibilities. A pharmacy shall develop a process for pharmacy staff to communicate requests for additional staff or reports of staffing concerns. Requests for additional staff or reports of staffing concerns shall be communicated in writing to the managing pharmacist or to the pharmacist who has been designated by the managing pharmacist to assume the managing pharmacist's duties in his or her absence. The managing pharmacist or his or her designee shall resolve any requests for additional staff or reports of staffing concerns in a timely manner or within 72 hours to ensure a safe working environment for pharmacy staff. If the managing pharmacist or his or her designee does not have authority to resolve the issues listed, they shall report the issue to the person of authority within 24 hours of receiving the request for additional staff or reports of staffing concerns, who shall resolve any issues listed in a timely manner or within 72 hours to ensure a safe working environment for pharmacy staff. A copy of the written request for additional staff or reports of staffing concerns shall be maintained in the pharmacy for 3 years for immediate inspection by an agent, inspector, or employee of the board. The managing pharmacist or his or her designee or the person of authority who is responsible for responding to a request for additional staff or reports or staffing concerns shall document their actions and provide a written response to the request or report or concern within 72 hours of submission, which must be communicated to the managing pharmacist or his or her designee and the pharmacy staff who submitted the request, report, or concern. A copy of the written response shall be maintained in the pharmacy for 3 years for immediate inspection by an agent, inspector, or employee of the board. The pharmacy shall not retaliate or discipline a pharmacist who, in good faith, makes a request for additional staff or reports staffing concerns pursuant to this section. As used in this section, retaliation or discipline includes but is not limited to the following: removing or suspending the employee from employment, withholding from the employee salary increases or employee benefits to which the employee is otherwise entitled, transferring or assigning the employee, denying the employee a promotion that otherwise would have been received, reducing the employee in pay, position, or scheduled work hours. Section 4, a pharmacy shall develop and implement a policy which shall be maintained in the pharmacy for immediate inspection by an agent inspector or employee of the board that permits the pharmacist to limit the provisions of non-dispensing services if in the pharmacist's professional judgment, the provision of such services cannot be safely provided or may negatively impact patient access to medications. The pharmacy's policy shall require pharmacy staff to make an appointment for a patient or refer a patient to another pharmacy offering immunizations or other non-dispensing services. Limit pharmacy access points. If in the pharmacist's professional judgment, limiting such access points will minimize fatigue, distraction, or other conditions which interfere with the pharmacist's ability to practice competently and safely. A pharmacy shall not override the control of a pharmacist on duty as follows. A pharmacist's decision to not administer or supervise immunizations or provide other non-dispensing services if, in the pharmacist's professional judgment, the provision of such services cannot be provided safely or may negatively impact patient access to medications, The pharmacy staff shall offer to make an appointment for the patient or refer the patient to another pharmacy offering immunization or other non-dispensing services. A pharmacist's decision to limit pharmacy access points, if in the pharmacist's professional judgment, limiting such access points will minimize fatigue, distraction, or other condition which interferes with the pharmacist's ability to practice competently and safely. Such limitation shall not interfere with the patient's ability to drop off or dispense prescriptions during the pharmacy's posted hours of operation. Subsection 1 does not apply to pharmacies that are not open to the public. A pharmacy shall not retaliate or discipline a pharmacist who in good faith acts in accordance with this section. As used in this section, retaliation or discipline includes but not limited to the following: removing or suspending the employee from employment, withholding from the employee salary increases or employee benefits to which the employee is otherwise entitled, transferring or reassigning the employee, denying the employee a promotion that otherwise would have been received, reducing the employee in pay, position, or scheduled work hours. Section 5. A pharmacy and managing pharmacist of the pharmacy that dispenses controlled substances or dangerous drugs shall ensure the pharmacy complies with sections 2 and 3 of the regulation to the extent applicable. A pharmacist who is on the staff of the pharmacy that dispenses controlled substances or dangerous drugs, including without limitation the managing pharmacist of such a pharmacy, shall report to the board when the pharmacy fails to meet the requirements of section 2 or 3 of this regulation, if in the professional judgment such failure may have compromised patient care and safety. Section 6. Except as otherwise provided in subsections A through K of this section, a prescription for a dangerous drug or medical device shall be filled within 3 business days upon the receipt of the prescription by a pharmacy or medical products provider, or if the prescription is a refill upon the request of the patient, except when a prior authorization or contact or clarification with the prescribing practitioner of the prescribed dangerous drug or medical device is required. The patient's insurance denies coverage of the medication and cash payment for the medication is not an option for the patient. The prescribing practitioner cancels the prescription upon reviewing the patient's record pursuant to NAC 639.707, section 4. Before dispensing the dangerous drugs or medical device prescription, it is determined that the prescription is therapeutically inappropriate for the patient or may negatively impact the patient. The prescription is determined to be unlawful, fraudulent, or not issued for a legitimate medical purpose. The pharmacy or medical products provider cannot fill the prescription as prescribed as a dangerous drug or medical device prescribed is not available because there is a documented drug shortage, the medication is on back order, or the drug is not available from the pharmacy's drug distributor. The pharmacy or medical products provider cannot access the prescription due to the temporary technologic or electronic failure in the computer system necessary to process the prescription, or is experiencing a power outage. The pharmacy or medical products provider cannot process prescription due to a natural disaster, a human disaster, or an outbreak of a pandemic, or the declaration of a state or federal emergency, or incident that significantly impacts the ability of the pharmacy or medical products provider to timely process the prescription. The prescription is for a compounded product, if applicable, based on when the patient last filled a prescription for the same drug and dosage, the patient is not yet due for a refill, or the board determines there is a reasonable reason why the pharmacy or medical products provider could not timely process a prescription. The pharmacy or medical products provider shall document the records of the prescription, the reason the prescription cannot be filled within 3 business days pursuant to this section. Section 7 is the change in the number of pharmaceutical technicians and technicians in training a pharmacist may supervise, and it has been changed from 3 to 4 in this section. And section 8 discusses when the effective date of this regulation will take place. I'll turn it over to the board.
I'll go first. I think Yen is ready to read the bills down at the next legislative session. Good job, Yen. Last thing, I want to appreciate the board's time, the staff's time, the attorneys, Yen's time, the stakeholders' time. And I think that we're at the point now where we can recognize that every state is dealing with this issue. There is an issue. It's how are you going to attempt to solve it to make it safer? And that is what your job is to do. So.
Great, thank you. So I think what I will go ahead and do next is open up the floor for public comment on this workshop item. I do want to emphasize to those out there that your comments are important to us. So if you're out there and you have something to share on this, your feedback is very welcome. It's appreciated. We want to hear from the pharmacists. We want to hear from future pharmacists, as it will help us determine the language for the regulation. So with that, I'll open up the floor for any public comment. If we have anyone in the room who wishes to make a public comment, if you can kind of form a line, that would be nice. And we'll just kind of keep it going, and then we'll go from the room to online.
Good morning.
Good morning.
Thank you for the time this morning. My name is Jessica Kovach, and I'm the Director of Pharmacy Government Affairs for Albertsons Companies. We operate 1,700 pharmacies nationally and 37 pharmacies in the state of Nevada under our banners of Albertsons, Safeway, Vons, and Save-On. We align with the board on the prioritization, patient and worker safety, but have concerns that certain elements of the draft language are unattainable and will have significant impact on patient access to care. With being respectful of time to comment today, I'd like to discuss Section 2 staffing requirements and highlight 3 specific concerns based on analysis of our 37 locations: staffing shortages, elimination of pharmacist autonomy, and variability in operating models. To meet the staffing requirements in Section 2, we would need to hire more pharmacists than the projected graduating class from Roseman University in 2026. And that's based on AACP's fall 2023 enrollments. Even if the percent overlap of open hours requirement were to be removed, we would still need to hire the entire graduating class to accommodate the non-dispensing pharmacist staffing requirements. We're not the largest company in Nevada, and as much as we would love it, I don't think every graduating pharmacist is going to join Team Albertsons. The staffing mandate is going to drastically change our pharmacists' work environment, eliminating the flexibility and autonomy they experience today with choosing when and where they work. Flex scheduling to accommodate strings of days off, working every 3rd or 4th weekend, that all goes away with the staffing mandate. Coverage for PTO and time off requests becomes more difficult in light of the labor shortage in Nevada. We believe this to be counterproductive with addressing the concerns that this intended rule is looking to address. The staffing requirement model also does not account for the operational variability in community pharmacies. I'm speaking on behalf of our 37 pharmacies, and all of our pharmacies operate different. And this is based on several factors that play into that. We have specific clinical service offerings in some of our locations. And I'm not just talking about immunizations. We do medication administration services for long-acting injectables for mental health and substance use disorders, as well as participate with contraceptive prescribing. And that impacts our Sparks, Fallon, Reno locations more heavily than in our Vegas locations. Central fill utilization to remove prescription filling workload at local pharmacies is something that we use as well in trying to alleviate the workload on the local pharmacies. And additionally, we have specific requests from communities about our hours of operation. So Fallon specifically, we open at 8 a.m. to accommodate the senior citizen population, whereas some of our peers open much later and actually are even closed on the weekends. Prescription volume does play into this, and the needs of our pharmacies vary. Our Vegas market is completely different than our pharmacies in Elko, Fallon, Sparks, and Reno. The staffing model proposed will have a significant impact on Albertsons pharmacies in Nevada. It's going to lead to reduced hours of operation, reduction and elimination of service offerings, and force difficult business decisions to be made regarding the continued operation of some of our pharmacies. All of these changes will have a direct impact on patient access to care. We ask that the board reconsider Section 2 entirely and continue to collaborate with stakeholders to consider language that incorporates potential model language from other states that have recently taken action to address similar concerns. I thank you for the time. I look forward to working with all of you as well as our peers on this issue.
Great, thank you for your comments. Okay, if we could have the next person please come forward. Hi, good morning.
Good morning. Thank you for the opportunity to speak today. My name is Victoria Kroger. I'm a manager of with the pharmacy affairs team with Walgreens. We admire the board's continued attention to the concerns raised around safe working conditions in pharmacies across Nevada. The decisions made here today will have a direct impact on patient access to timely, safe, and effective pharmacy care across Nevada, and we truly value your ongoing commitment. Community pharmacies are navigating a period of significant challenges marked by closures, staffing shortages, and increasing prescription volume and expectations by the public to deliver clinical services. Alarmingly, data from the National Community Pharmacists Association shows that an average of 3 community pharmacies closed each day in 2023, a trend that has only intensified through 2024 and into 2025. We are concerned that the proposed regulations will unintentionally accelerate pharmacy closures and result in a reduction in pharmacy hours throughout Nevada, deepening health disparities and delaying patient care as they introduce several significant implementation challenges. More specifically, we have 3 main areas of concern regarding the proposed regulations. First, rigid staffing minimums tied to arbitrary prescription volumes or percentages of operating hours, which overlook fluctuations in demand and the unique challenges faced by rural or lower volume pharmacies. Further, these regulations fail to consider the variable operating models that exist today in practice. More specifically, the support provided by centralized service pharmacists, technicians, and other support staff from off-site locations. Secondly, a well-known nationwide shortage of pharmacists, with an estimated 14,200 openings for pharmacists each year on average, and a significant drop in the number of students pursuing pharmacy careers will make it increasingly difficult to meet the mandated staffing levels, both now and in the future, particularly in those areas where recruitment and retention are already a challenge. And finally, the proposed requirement for a dedicated pharmacist to provide non-dispensing services will likely force pharmacies to scale back vaccine administration or medication administration for medications such as long-acting antipsychotics, as many will be unable to staff these services during all hours that they are typically offered, nor will the volume of non-dispensing activities compensate for the added cost of the staffing mandate. This reduction in availability, particularly during evening and weekends, when at least 25% of vaccines are currently administered, could be devastating for individuals who depend on non-peak hours, such as those that work in many of the 24-hour businesses that exist in Las Vegas, families who depend on nights and weekend hours to prevent parents from missing work and children from missing school to attend these appointments, or other patients who just simply need or simply have limited availability. We strongly urge the board to reconsider the proposed staffing mandates tied to arbitrary prescription volume and operating hours. Instead, we advocate for a modernized, adaptable approach that includes provisions for centralized services and recognizes the evolving role of pharmacy personnel. Centralized services such as remote verification, central fill, shared clinical support are not merely operational efficiencies. These are essential tools for mandating patient safety, reducing errors, and ensuring continuity of care. By shifting tasks to secure centralized teams, on-site pharmacists are free to focus on direct patient care. We urge the Nevada board to remove the requirement for an additional pharmacist to dedicated non-dispensing services. This mandate overlooks the vital role of pharmacy technicians, who many are also trained and authorized to administer immunizations, conduct health screenings, and support medication therapy management. We have acted in good faith to provide constructive feedback to the board staff throughout this process. However, the current proposal does not reflect the realities of pharmacy practice and risks creating regulations that compromise patient access and further strain limited resources. We remain willing to collaborate to ensure the final rules are both practical and aligned with the needs of patients and the pharmacy workforce. We would be happy to provide an alternative language to the board that could be used as an alternative to section 2. Thank you very much.
Great, thank you for your comments. Thank you. And if we could continue to have people queue to speak next, just to move things going. Hi, good morning.
Good morning, board. I'm Lori Wamsley, Director of Pharmacy Affairs on behalf of Walgreens. Thank you for the opportunity to address today. I'd first off like to start off by expressing my appreciation to the board and the board staff for the continued efforts to ensure that patient safety and strengthening the pharmacy practice in Nevada, including the proposal to increase the technician pharmacist ratio for supervision that's included in this proposal. This is a meaningful step towards recognizing the evolving role of technicians in the supporting more efficient workflows. However, we must also acknowledge that this expanded ratio has limited impact on pharmacies if they cannot meet the proposed staffing mandate. I would also like to highlight with the board, pharmacists face unique administrative burdens typically not seen in other states in Nevada. These include sequential prescription filing, prescription stickering, and extensive documentation requirements for things like patient consultations. Such regulations reduce pharmacists' time with patients and contribute to professional burnout and make staff retention more difficult. A 2021 report from the Nevada Globe ranked Nevada among the most burdensome states for regulatory compliance. Also, an analysis that was published in 2020 of pharmacy statutes and regulations across 10 Western US states, including Nevada, looked to quantify regulatory burden supports the argument that Nevada's regulatory framework is among the most complex and burdensome in the country. We believe that the board has an opportunity to reduce these barriers and regulatory complexities, which would enable pharmacists to focus more time on clinical care and to improve patient outcomes. We would be happy to provide some additional language to the board that would remove some of the administrative burdens if the board is interested. I want to be crystal clear that our goal is not only to reduce administrative burdens, but it's also to improve safe and sustainable practice conditions for pharmacists in Nevada. Other states have taken meaningful steps to protect pharmacy staff while maintaining patient safety, reforms that we believe that Nevada can feasibly adopt that will not take a one-size-fits-all approach to this regulation. As Dr. Reeves mentioned, the basis of the language that was provided by the industry stakeholders is from Ohio, but there are other states that could also be considered. California, for example, requires community pharmacies to have at least one dedicated technician or clerk on duty during specific business hours unless otherwise exempted. The pharmacist in charge is authorized to adjust staffing to prevent unsafe conditions and document changes when necessary. These requirements were outlined in Assembly Bill 1286 and aim to support pharmacy operations and reduce fatigue. Oregon requires adequate staffing and guarantees uninterrupted rest and meal breaks and allows pharmacists to suspend services if patient care is compromised. The proposed staffing rule offers a critical opportunity to modernize pharmacy practice in Nevada, but true modernization requires more than rigid headcounts. It requires flexibility and recognition of the expanding role of both pharmacists and technicians and trust in the pharmacist's professional judgment. Pharmacists have a meaningful voice in staffing decisions and the ability to raise concerns without fear of retaliation. While the board has outlined the process for doing so, the requirements remain overly burdensome and impractical for real-world implementation. We urge the board not only to consider regulatory mandates, but also the broader impact on patient access and workforce sustainability. Nevada should align its regulations with national best practices, reducing unnecessary burdens and supporting a model that empowers pharmacists to deliver high quality care. The reality is clear, there are not enough pharmacists statewide to meet these proposed mandates. If implemented as written, these rules risk reducing access to essential services, especially in underserved communities. We need a regulatory framework that reflects a modern pharmacy practice and leverages the full scope of the pharmacy team and prioritizes patient care. Thank you again for the opportunity to speak today. We appreciate the board's efforts to collaborate with stakeholders, and I'm happy to answer any questions that you may have.
Thank you for your comments today.
Thank you.
Morning, Madam President, members of the board. My name is Rob Geddes, and I'm an Executive Director of Pharmacy Advocacy and Regulatory Affairs for CVS Pharmacy. First and foremost, I want to thank the board for the opportunity for stakeholders to engage with the board during this workshop and future workshops on this important topic. I want to especially thank the board president Park and board member Tomaso for the additional work they have done in and outside of regular scheduled board meetings. As many of you are aware, CVS Pharmacy has been making strides to support our pharmacists and technicians in Nevada to improve their ability to continue providing safe and effective access to important pharmacy services. I'd like to offer some suggestions to modify language which we believe can mitigate some of the unintended consequences that have been described by others today. I don't feel the need to cover those or duplicate those, but want to talk about some of the changes that we think might be meaningful to allow for continued public access to the important and often life-saving pharmacy services. I'll briefly walk through our justification for the changes in order of their appearance within the regulations. First, the current suggested overlap of 80% of hours of operation each day is not sustainable. Additionally, based on our calculations of this staffing models, it will result in 51% of the tasks completed by a pharmacist being work that could have been performed by a technician, thus diminishing the education, training, and experience of a pharmacist. CVS estimates that these proposed regulations as written will require the addition of approximately 120 full-time pharmacists in our pharmacies within the state. Based on the available data, we're concerned that this will be an impossible number of pharmacists to hire today and an unsustainable level of pharmacists maintained considering the attrition rates and future deficit in pharmacists graduating from school. Based on these concerns, we suggest 4 modifications for the board to consider primarily in section 2. First, we suggest lowering the percentage from 80% down to 20%, making it a little closer to a sustainable level. Second, we would ask the board to consider basing that percentage on weekly hours and not hours each day, which would allow the business the flexibility to determine which days of the week would benefit most from those overlap hours. As an example, not needing to use them on a weekend where patient pickups may be lower. Third, suggest exempting the overnight hours from 9 a.m. to 9 p.m. in the 24-hour locations from the calculation for overlap and remove the 65% nuance that is related to 24-hour pharmacies. I think that would make that more manageable. And then lastly, for this section, we asked the requirement for the second technician or intern when a drive-through is present be removed in favor of the pharmacist having the autonomy to reduce access points if they feel they're not staffed appropriately to keep them open. Moving to the next area of concern, potential for decreased access to immunization. I think that those who've spoken before me have highlighted the concern that the additional pharmacists required by subpart 3 of section 2 can lead to decreased offerings of those services in the marketplace. So this language one of the things that we had suggested was the limiting of access points, and that was intended to replace the need for the additional pharmacist to provide the non-dispensing services and give that the pharmacists that are working the autonomy to flex or not offer those depending on the circumstances of the day if they feel they're not staffed appropriately to be able to provide immunizations as an example. The language that we had suggested was not meant to be in addition to, it was meant to replace that non-dispensing pharmacist language that carried forward from the previous proposal. So we suggest that the board consider removing that requirement in section 2, subpart 3 altogether, and then in favor of the language found in section 4 that grants pharmacists autonomy to offer these services. Last couple here are pretty quick. With regard to the staffing form, our primary concern as we've implemented this in other states, Ohio, Virginia, and a few others, the time that we've had to be able to go through a thoughtful process to respond to any of the concerns raised via the form has been approximately 14 days. We found that 14 days has been sufficient to engage in that process with the pharmacy, review the concerns, and then provide an action plan that helps address the concerns that are present. We're concerned that having to comply with a 72-hour turnaround would create challenges to engage in that process, and would request that the board consider increasing from 72 hours to 14 days total for that process to occur. Last part about the language is related to the significant delay language. Again, this comes from Ohio, and it's something that we only thing that we would ask the board to change here is the requirement to document the exemption on these prescriptions. Our concern is that the exemptions are robust. They include pretty much everything we could contemplate that could happen that would delay a prescription. However, the amount of prior authorizations or back orders or number of times that those exemptions would occur would likely lead to additional administrative burden for the pharmacist to track. Has it been 3 days? When do I need to document the reason that this prescription is late? So if at all possible, if we could remove that exemption portion, we would have it. In the event that there are concerns raised by the public to the board related to prescriptions being delayed, that there will be ample opportunity for conversation between the pharmacy and the inspectors to identify what was the cause of that delay, whether it was covered by an exemption or not. And would save a lot of time for the pharmacist not to have to do the additional documentation. And lastly, as you consider the changes we've suggested today, I would also request that you consider a minimum of 1 year for delayed implementation with these new changes, as additional staff will have to be recruited and hired. Want to thank you for your time, your consideration, all the work that's been put into this, and the future work that we can engage as stakeholders with this board. I'm happy to stand for any questions if you may have any. Thank you.
If I can I ask a couple? Sorry, I'll be quick. So if we go to section 4 and 5, I was listening, but I'm doing a lot of other things too. So I didn't hear that you commented on 4 and 5. I think with your other comments, 5 would go away because you want that removed. So 4, I think would still stay. Do you?
I would say two.
I know, I think he was saying that they don't want 5 is about the,
He's talking about documentation of why we can fill a prescription within 72 hours. So he's talking.
no, I'm talking about something else.
So section 5,
Section 2, subsection 4. To be more clear.
section 2, subsection 4, didn't have any suggestions there, I think.
Okay, but 5, subsection 5, you would go away because you don't,
Correct.
because you're saying that you don't, and I didn't say subsection 2, so to your point, yeah. But is that 4 would stay in place based off of your comments, and is that the right number, or? That's the number based off of the pharmacist wanted in the survey, based off of 80%. So we took their number and then down it to 80%. So you don't have to have a comment. I'm just wondering.
Well, I mean, I have a perspective I'll share.
Okay.
I mean, the CVS with the volumes that our stores are operating.
Oh, they're all over it.
The minimum, the 100 prescription cutoff would not be as useful to our company. However, I think there are other companies that probably is more meaningful to. CVS, we probably, if we were to look at, exclude some of what we consider to be a lower volume store, we would need that number to be probably closer to 300.
Okay.
Just as an idea.
That makes sense. And that's a fine route. And I understand, like, we'll probably have some independent comment and that might have more meaning to them. So I didn't get the nuance that you would be over that regardless of what happened. So gotcha. And then, as you know, when we did this, we removed the top end so that you're not adding pharmacists after adding pharmacists. Your top end is for you to figure out. So, yeah.
Right, yeah, we agree with that, and we think that we're looking at a new direction that we can have some engagement on, and I think that this is meaningful to start looking at the different solutions that could be out there. We'd love to engage further on some of the technology solutions to be able to allow for greater support that maybe comes from outside of the pharmacy, but that can be for another day, but definitely appreciate the opportunity to be here to speak. I know I went through a lot of specific changes that I outlined. I'm happy to work with Dave and staff to just provide a little more clarity on some of those if the board members would desire. We could do that offline outside of the meeting. I can provide some working notes that we've looked at. But
We have, I mean, Yen and I have them. I just wanted to get that clarification. So.
Okay. All right, thank you. Any other?
No, thank you for your comments. Appreciate them. Hi, good morning.
Hello and good morning, Madam President and esteemed members of the board. My name is Jeffrey Bizarre. It is an honor and a pleasure to speak to you today regarding this proposed regulation. I am a proud Northern Nevadan who began his career in pharmacy here in Reno as a pharmacy technician in 2016. And today I am lucky and overjoyed to continue my practice as a pharmacist in my favorite city. Unfortunately, I'm opposed to this proposed regulation for the following reasons. I do not believe that our market in northern Nevada is poised to fulfill the positions that will be required by this proposed regulation. Plainly, I don't think that there are enough pharmacists for retail pharmacies in our area. It sounds like that feeling's been shared by other members of higher positions in these corporations. I believe this because my pharmacy, which is the local Walgreens specialty pharmacy, has faced significant difficulty in hiring a new staff pharmacist for more than the past year. We don't feel comfortable simply pulling someone into maybe a more desirable or more preferred position from a retail store if that store is in need of supporting their patients, their population in my neighborhood. For months, we have been actively recruiting now, but we struggle even to interview lately. While we are eager to bring on a new team member, we're not interested in being pressured to hire the wrong person just to meet some sort of staffing quota or baseline requirement. I fear that this regulation would lead to a reduction in services and potential closures in pharmacies. Pharmacists are the most accessible healthcare professionals, and we are proud of it. The accessibility of these non-dispensing services is critical for busy Nevadans who often struggle to balance hard work hours, family responsibilities, and the difficulty of scheduling routine healthcare. I fear that this regulation would prevent neighborhood pharmacies from offering any non-dispensing services, not because the pharmacists are unable, unskilled, not capable enough, but because they deem it or rather not even because they deem it unsafe for them to attempt to give these services, but because they may have been instructed directly not to. I am worried I'm going to hear one of my cohorts deny providing a vaccine that they would otherwise feel comfortable doing because there's just no vaccine pharmacist today. In short, I am very proud of my board of pharmacy that has proposed regulations with a direct aim of protecting pharmacists. And I am in favor of the language presented in sections 3 and 4, which empower me as a knowledgeable expert in managing the daily operations of my pharmacy. I am not in favor of the language presented in section 2, which outlines staffing requirements I believe are both too strict and unfortunately not currently feasible in Northern Nevada. Thank you very much for your time.
Thank you for your comments. Good to see you. Hi, good morning.
Good.
Good, how are you?
So I want to introduce myself. My name is Tabitha Salgado. I'm currently a registered pharmacist in Nevada. I work inside of CVS, inside of a Target. And to put in perspective, I'm considered a lower volume store, but exceed 100 scripts per day. And I've been in pharmacy for 12 years. I did start as a technician, and for the past 4 years, I've been a pharmacist. I wanted to discuss some of my concerns in regards to the recent proposals. First, I wanted to say thank you for addressing the help that is desperately needed in pharmacy. Pharmacy is tough, and having an extra hand is amazing. But I do feel we're overlooking our technicians and the value that they bring. In my pharmacy specifically, having an additional pharmacist 80% of the time would mean a majority of the day, the pharmacist would be doing technician duties versus clinical duties. This isn't allowing us to work at the top of our licensure that we've worked so hard for. And this is also limiting my technicians. My fear is that I may lose them in my case. If there's a pharmacist taking over their responsibilities, what's the need for the technician itself? Additionally, my clinical judgment and my technician's abilities are being overlooked and limited. I became a pharmacist because I'm passionate about helping people and being available to them. I know from experience, trying to get to see a doctor can be challenging and it may take months. I take pride in being that person that my patients turn to and seek out for guidance and support when they can't get it from their provider. I don't want to be part of the problem of limited healthcare access. I want to be the solution. My one example would be, providing vaccinations. According to the proposal, I would not be able to vaccinate patients if I'm the only pharmacist. Have we forgot technicians can administer vaccinations as well? At my store, my technicians give about 80% of my vaccinations, and this allows me to be available for my patients and my clinical duties. I just want to put it in perspective. Look, I'm a mom and I vaccinate my child, and I have to work up to that. I have to convince her, and finally I get her to go, and I'm rejected by the pharmacist. Even though there's a pharmacist on duty, I personally would be upset. Ultimately, I want to be able to utilize my clinical abilities and be able to make that judgment call myself where I see the need. And also allow my technicians to work to the top of their licensure. I don't want us to overlook them because in the time of need, when we needed them during COVID, they played a pivotal role for us as pharmacists. I just don't want that to go unlooked or unnoticed. I don't want to be that pharmacist that turns away a mom or even an elderly patient that already has limited mobility because by law, I need an additional pharmacist. I am the capable pharmacist, and my technicians are too. We're supposed to be accessible and be able to close those gaps. I wanted to give a different perspective today. Yes, having a pharmacist help is amazing, but what about additional technician help? They're invaluable and are a big part of pharmacy. Personally, I want to see more technicians and stability for them. I honestly believe if we do that, that will improve patient safety due to less turnover and retraining. Also, this helps the pharmacist focus on their duties versus being pulled away to support technician duties. I believe it takes a strong team to actually make a pharmacy work. And adding on an additional pharmacist doesn't help the lack of technicians that we don't have. Thank you for your time, and I'm open for any questions.
Appreciate your comments. Thank you.
Sorry, would you mind sharing what your average daily volume is at your store?
Daily volume?
Yeah.
I would say around 200 to 250 a day.
Thank you.
Hi, good morning.
Good morning, Liz McMiniman, Retail Association in Nevada, representing the community pharmacies here in Nevada. Good morning, Madam President and members of the Board of Pharmacy. I appreciate the board taking the time to bring this regulation back for further review. I also appreciate the opportunity we had to submit language to the board that we believe addresses some of the concerns that you've expressed regarding the industry. However, this morning we have come to you and have to oppose the language that is before you in this workshop because the industry believes this is an unfunded mandate on the industry in the state of Nevada that could have wide-reaching consequences on the delivery of healthcare to the residents here in Nevada. We have looked at other states and the different approaches that they have taken and incorporated it into our proposal that I am not even sure if any of you have seen other than the president and the board member. I'm not sure if staff had submitted to you our proposal that we brought to the governor's office. But we had considered all of these things when we submitted this, and we had an alternate proposal for this board to look at. I'm sure that this is not the board's attempt to put pharmacies out of business, reduce access for patients, or even jeopardize jobs for pharmacists and the pharmacy technicians in the state of Nevada. That being said, we believe that the new language would provide what you were looking for. One of our smaller members came to me and discussed having to increase staffing by 150% and possibly close a third of their stores. You heard from one member today who gave you options, but that's one of the large members. I will address that later about this cookie cutter approach because I don't believe it would work. These closures for these small members would likely, most likely be in rural, underserved communities. Specifically, one community they said would have to be closed because there's no way that they could even fulfill staffing that store in a rural community because right now they have a hard time staffing that, getting somebody to go to some of those rural communities such as Hawthorne. And I'll use Hawthorne as an example because it's not somewhere everybody wants to go. So, I mean, it's just a very difficult, even offering bonuses, and they found that it's very hard to staff there. This member would have also had to consider possibility of limiting the hours of the pharmacy that would be able to operate, or reconsider offering services such as vaccinations, contraceptive controls, or other clinical services going forward. This is just a small sampling of the membership that have stated that in order to comply, they would have to have the availability. I had 4 members that I discussed, and the total pharmacists that they would need to comply with this regulation within 90 days of passage would be 600 new pharmacists. That's just 4. That's not all the pharmacies in the state of Nevada. That's if those 4 pharmacies were able to grab every pharmacist out there, and I don't even believe that there's 600 out there. Rand believes that this cookie cutter approach to staffing in a pharmacy as proposed by the board language is untenable. And as I stated, would impact the rural and the lower socioeconomic areas, even in Las Vegas today. That is because each pharmacy has unique operating systems, and many are not sure of even how impactful this staffing requirement would ultimately end up being, and how many stores that they would possibly have to close, limit hours, change complete policies and the way that they do business in Nevada. Our proposal that I talked about has taken into account particular environments in each and every pharmacy out there and how they staff their pharmacy by utilizing the pharmacist's professional judgment to maintain safe working environments while still providing the health care that the residents in Nevada need on a day-to-day basis. The industry is here today to discuss, as you have heard, all of their concerns and ask you please to listen to their words and to consider how this would impact each of them in many different ways. I myself have heard from individual members, and I hope that you as board members listen today, how the unintended consequences of this regulation, even the one brought forward today with everything thrown in it, would impact healthcare in our state. Again, I want to, there was also the added section now for the administrative cost on the inability to fill a prescription. I believe that section needs to completely go away. I think that that's adding a new administrative burden on the pharmacist who's already overburdened in the pharmacy. There are a multitude of reasons why, and as stated before, there are ways for the investigator, the inspector, whoever's in the pharmacy, and the pharmacist to be able to ascertain why that happened and why they didn't necessarily get their medication within 72 hours. And I know the board staff hears of the complaints from the patient out there, and I understand that, and I understand their concern on that. However, this administrative burden is another new burden that's being placed on the pharmacist in our pharmacy trying to take care of our patients. Again, I want to give my appreciation to the board president and to the public member and the board staff that met with us to discuss these issues with the governor. I do not believe this administration nor this board has the desire to implement regulations that would detrimentally impact the citizens of Nevada. Thank you for your time, and I am open for any questions you may have. And I do have a copy of what we submitted. If you as a board member was not privy, I'm not sure, Dave, did you provide? I guess I have a question, and I know it's that one, but did you provide what we submitted to you guys, to the board members?
Yeah, I should, Dave, Weiss, for the record, I should point that out because it's one step by step. Everything we've received has been provided to you. We did, not yours, we've received others that was related to and you've seen this, we've received others that were related to R11324, which is not in front of you today, but we made the assumption that it was about this. If that language would come back, we would give it to you at that time too. But every public comment that we got related to staffing is in front of you. Okay. Thanks, Liz.
Great. Thank you for your comments today.
Thank you so much, Madam President.
Good morning.
Hey, good morning. Thank you for your time. My name is Stephen Ohana. I'm one of the smaller members that you talked about. So I currently work as a pharmacy manager in Sparks, used to be a distributor for a retailer in the past. I wanted to thank the Board of Pharmacy for conducting the surveys and making a good faith effort to improve the working environment for licensees. And I do agree that steps should be taken to alleviate the stress experienced in pharmacies, not only for pharmacists, but also for technicians. With respect to section 2.1, I do have some concerns regarding its impact on patient care and underserved communities. As a pharmacist, my goal is to provide the highest level of care to the greatest number of patients, particularly in rural and hard-to-staff regions such as Northern Nevada and surrounding areas. I believe this requirement may inadvertently limit our ability to do that. For example, if a pharmacist were to call out one of these areas, the pharmacy would be restricted to filling only 100 prescriptions and unable to provide essential services such as immunization. This would significantly reduce access to care for patients who are already facing limited healthcare options. Having supported outlying markets in multiple states, I understand the significant challenges of recruiting qualified pharmacists to these areas. The number of pharmacists required to obtain current pharmacy operations would be substantial. And with pharmacy school admission rates declining while retirement continues, I'm uncertain how such staffing expectations could be realistically met. I'm concerned that this proposal may unintentionally lead to the reallocation of resources in ways that negatively impact patient access to care. Pharmacies could be forced to reduce operating hours or close temporarily or even permanently, with pharmacists being redirected to other locations. From my experiences working in a pharmacy with reduced hours and closed on weekends, I've seen firsthand how this limits pharmacists' abilities to meet patients' needs. Patients would often tell me that they were required to leave work early or travel to alternative locations on the weekends, which created significant barriers to accessing their medication and other essential services. This could result in the creation of centralized hub sites similar to hospitals or large retail chains, thereby limiting access for patients in rural communities. For these patients, increased travel distances would make it far more difficult to obtain medication and other essential health services, placing additional burden on an already underserved population. This demand on pharmacists is further compounded by Section 2.3, which includes non-dispensing responsibilities such as immunizations. During the COVID-19 pandemic, the board did an excellent job by taking steps to allow certified technicians to administer vaccines. This not only served the public interest, but also alleviated much of the burden on the pharmacists. That period highlighted the value of allowing certified technicians to practice at the top of their licenses by safely and efficiently administering medications. It demonstrated the need for certified immunizers, but not necessarily additional pharmacists on every shift. This regulation would reverse the recent progress by requiring pharmacists to provide immunizations, even though trained technicians have demonstrated proficiency in vaccine administration. Section 2.2 would also require 2 non-pharmacy staff if the pharmacy operates a drive-through. This requirement could become problematic if the patient calls out, as the pharmacy could be forced to close completely in the absence of overlapping staff, or at a minimum, close the drive-through. This would directly limit patient access, especially for those who rely on drive-through services to drop off and pick up medications. While Section 4.2 addresses this issue in part, further clarification would be needed on how to ensure that such restrictions do not interfere with the patient's ability to obtain their medications if they are unable to enter the pharmacy in person. I respectfully urge the board to consider alternative approaches that balances the need to reduce workplace stress with the necessity of maintaining access to care, particularly in rural and underserved areas. I want to build the expanding the technician to pharmacist ratio, maybe having more transparency in pharmacy budget calculations, and having input that is actioned upon by the employers would be helpful steps in achieving this balance. Thank you so much for your time, and I appreciate you guys.
Thank you for your comments. Do we have anyone else in the room who wishes to make a public comment on this workshop item? I do see that we have a number of people online, but just checking, I don't see anyone in the room. I think,
If 6, just so you know, we have 6 or 7 that raise their hand. It doesn't mean that there won't be more than that, just letting you know.
that's okay. I think for now that went a little bit longer, which is great. Appreciate the public comment. We're gonna just take a quick break and then we'll be back. Okay, great. Welcome back to the Board of Pharmacy meeting. We're still in public comment for our workshop item. I'm gonna move now to public comment that is online. So if we have people online who would like to make a public comment on this workshop item, if you could please raise your hand on Zoom, and I see some hands, or let us know through the chat function, and we will get through the through each of you.
Start off with Barrington Ward. Your line's unmuted.
Thank you. My name is Matthew Christensen. I'm an independent pharmacist in Northern Nevada. I own 3 stores, and I would first like to applaud your efforts to improve the working conditions for the pharmacists in Nevada. In independent pharmacy, it's not really a huge issue since we're probably overstaffed as pharmacy standards go. But I do know the results of the survey reflect the unsafe working conditions that some pharmacists do have. And I believe that all these can be affected by this, and I'm glad that you're taking these steps. I know that even though probably there's not a lot of problems in the independent pharmacy, I know we can't be exempted, but to have the 100 prescription limit does make some problems for independent pharmacy, I believe, in the state. I know the economics of independent pharmacy, and I believe that if this goes forward as proposed, just about every independent pharmacy would have to close. I know I'd have to close at least one of my locations, maybe even two. So I don't think it can go forward as proposed for section 2, items 4 and 5 and 1, because 100 is just too low for the economics of pharmacy. And I would suggest to the board to go with a limit that's what you would perceive as too high, and then decrease that as you need to. My recommendation would be approximately 300 a day, and then maybe after that 200 a day. I was surprised that you only put limits on the lower end and not the upper end, because it's the upper end that pharmacists really get overworked. But you've done studies and you know more about that than I do. As for vaccinations, I would also recommend not trying to limit the amount of vaccinations that we do. I would just recommend that they be included in that calculation, maybe counting as 5 prescriptions towards whatever daily limit you impose. That way we could still perform them, or technicians can, and still serve the public. Although for my end, I don't make a lot of money on the vaccinations. I do it more as a public service. So if I have to discontinue those, that wouldn't hurt me too much economically, but it would hurt the public. The other item I would have some issues with is, I believe, section 6, the provisions for not filling it within 72 hours. There's one that I think is missing, and I might not be well informed on this, but I didn't find it in there. Items that we do not currently stock. Sometimes a doctor will write for an expensive medication or a brand name when there's generic available for, say, brand name Percocet number 3 tablets. We don't stock that. We won't stock that. We have to be able to refuse that prescription. And as written, I don't see an exemption where we could either refuse that prescription or not get it filled within the 72 hours. I would welcome any questions that the board has for me, and I would be willing to be a contact for independent pharmacy if the board has further questions, not during the board meeting.
Appreciate that, Matthew, and thank you for your comments today. Okay, we'll move on to our next public comment. Michael Kruger.
Good morning. My name is Mikhail Kruger, and I'm a pharmacy manager with Albertsons Save-On Pharmacy down in Henderson. I'm here today to speak from the perspective of both a pharmacist and a member of the Henderson community. First, I want to say that I support the ideas and intentions behind these proposed regulations. I believe the board is trying to do what's in the best interest of both patients and pharmacists, which should be everyone's goal. However, I think we can improve some of the details. I'm concerned that the current proposal will create too much hardship for our pharmacy and our ability to care for patients. If we're required to bring on a second pharmacist 80% of the time, we'll need to make major cuts elsewhere to offset the cost. My concern is that this will have to include reductions in pharmacist hours and/or pharmacy closures. If we are less frequently available or have fewer locations, it will be harder for patients to access pharmacy services. Last flu season, our pharmacy provided over 2,000 total vaccines through a combination of walk-ins, appointments, and community outreach clinics. We also provide monthly medication administration for several of our patients. Neither of these services felt overwhelming for one pharmacist to handle. I believe it's unnecessary to require an additional pharmacist for these non-dispensing services across the board, especially when having trained technicians to help provide vaccines has been so successful. My greatest concern, however, is that these regulations may end up having the opposite effect of what's intended. If there are few fewer pharmacies and pharmacist hours available, it will create more barriers for patients. We have numerous patients who walk to our pharmacy from nearby housing. Many of them physically or financially can't afford to drive. A decade ago, this very pharmacy I now manage was sold to a Hagen and closed several months later. I remember the struggles our patients faced, and it's not something I want them to go through once more. Again, I fully support the intentions behind the proposed regulations. It's important to promote patient safety and protect pharmacists from burnout that could compromise that safety. But I strongly believe more conversation and compromise are needed. If the board, companies, pharmacists, and patients can come together and work together, we can refine these details and achieve our shared goal. Thank you for your time.
Great, thank you so much for your comments. We appreciate it. Right, we'll move on to our next public speaker.
Roseman, P1 class.
Uh-oh. Be a lot of people.
Could be. These are our future pharmacists.
Yeah.
Good morning, members of the board. My name is Michaela Claybrook, and I'm a P1 student at Roseman University here on the Henderson campus. First of all, I want to thank you for the opportunity to speak. As a pharmacy intern, I would like to share a concern regarding subsection 2, which allows pharmacy interns to be included in staffing ratios. Before beginning pharmacy school, I worked as a pharmacy technician, so I understand firsthand the staffing challenges that this subsection is trying to address. Ensuring adequate support to prevent pharmacist burnout and to maintain patient safety is critically important, and I deeply respect the intent behind this proposal. However, including interns in staffing ratios, whether they are paid interns or not, is not the most effective solution. Interns are in a unique role. We are here to learn how to become pharmacists through a balance of coursework and experiential education. While we are eager to contribute, our time in the pharmacy should be centered on learning, observation, and mentorship. If we are counted towards staffing minimums, we risk being immersed in workflow demands instead of focusing on skill development. This can reduce the educational value of our introductory and advanced pharmacy practice experiences and limit our ability to gain deeper knowledge and competencies we need to serve the patients as future pharmacists. By counting interns towards staffing ratios, this section would require us to be dedicated solely to dispensing duties, when in reality, our education requires balanced exposure to both dispensing and non-dispensing responsibilities in order to fully prepare us for practice. For this reason, I respectfully propose that pharmacy interns not be included in staffing ratio requirements of subsection 2, subpart 2, so that we can prioritize both our education and the profession's long-term commitment to patient care and safety. Thank you for your time, and I am open to any questions you may have for me and my P1 classmates.
Thank you for your comments, Michaela. Appreciate that. Bring up some interesting points. All right, do we have any other comments from Roseman University or any other students while we're in the classroom?
They lowered their hand.
Okay,
They can always re-raise it.
all right. Okay,
Next person.
Lisa Modu.
Lisa, please pronounce your name for the record. If you have two devices on, you may get some reverb.
Yes. Okay, can you hear me?
yes, but we still have the reverb. Oops.
All right, we'll come back to her. Let's go to the next one. Yeah, and to keep us going.
Yep, Vesper.
Oh,
Pharmacy-
Roseman raised their hand again, maybe.
The Vesper Pharmacy
Okay.
for now.
Can you hear me?
Yes, we could hear you. Hi.
Good morning, Joshua.
Hi, my name is Joshua Karogli. I'm the owner and PIC of Vesper Specialty Pharmacy. We're a small independent pharmacy that does an average of 220 prescriptions a day, but we also do have days where it can reach over 400. We do also offer other services, including vaccines, MTM, and delivery. I wanted to speak in opposition of the proposed regulations of the pharmacy staffing, specifically in the required number of pharmacists. On behalf of myself, and I'm sure I can speak on behalf of the other independent pharmacies, this would literally and bluntly put us out of business. In a climate where we are fighting to keep our doors open in a highly competitive market and constantly dwindling reimbursement rates, this is not only not practical, but also not financially feasible or possible. The majority of independent pharmacists are family-owned small businesses of which we don't have the means, the financials, or the staffing power to compete with the larger chains. It's evident that we are both on the same side here in opposition to this. This proposed regulation would burden us independents financially and in most cases not make it possible for us to profit. And if we have to have an additional pharmacist or even two or more, since we do provide multiple services. Most of us are owners and PICs with one pharmacist, and we don't often take vacations, as is often too costly to hire coverage for a pharmacist and hard to find somebody that's qualified or trained to use our specific pharmacy systems, as they're not universal. If this were to succeed as is, I would have to let go of all of my technicians just to hire one pharmacist in addition to myself and run an even smaller team, which would actually go in the opposite of what we're trying to do here. I would kindly ask that you consider the impact that this would have on all of our mom and pop operations. And at the minimum, the threshold should be increased significantly. I want to use the number 500 because it's the top end where we have the issues, not on the lower end. And there should be, if possible, an exemption for small private pharmacies that are not corporations, as this would make it very hard for us to operate. The board should keep in mind that we have a completely different business models, and there can't be a blanket approach across all different types of pharmacies. And I'm very much in favor of increasing the technician ratio and actually expanding what the technicians are allowed and able to do. On one other point, I would like to add that I agree with the previous speakers that the whole section about documenting refusals on prescriptions within 72 hours should completely be removed. It's not practical, as mentioned by the other independent pharmacy as well, that there are things that we do not stock, we do not carry, and we sometimes can't afford to keep, and this would just make it impractical for us to do. I thank you for your time and consideration. I appreciate the board's effort in addressing patient safety.
Great, thank you so much for your comments.
Thank you.
Right, this is Nicole Baker.
Hi, can you hear me?
Hi, yes, we could hear you.
Hi, my name's Nicole Baker and I've been a community pharmacist and pharmacy manager for the past 13 years. Thank you for the opportunity to speak today. I'm here to express.
I was nervous as shit.
I am here to express deep concern regarding the proposed staffing language that would require pharmacists dispensing over 100 prescriptions daily to maintain 2 pharmacists on site 80% of the time and a third pharmacist for any clinical services, and then a minimum of 2 technicians for drive-through operations. While the intention behind the proposal may be rooted in patient safety and quality assurance, the language does not reflect the operational realities of modern retail pharmacy. It overlooks the significant support we receive from centralized fulfillment centers and workflow balancing technologies that have streamlined prescription processing and reduced the need for manual labor. In fact, over 90% of prescriptions are now received electronically, minimizing transcription errors and allowing pharmacists to focus more on patient care. Mandating rigid staffing ratios without accounting for these efficiencies will not only strain pharmacy operations, it will also have unintended consequences for the profession itself. Corporations faced with increased labor costs are likely to respond by reducing pharmacists' wages, cutting hours, or limiting clinical services altogether. This undermines the value of our profession and discourages talented individuals from pursuing or remaining in pharmacy careers. Furthermore, the proposed requirements could disproportionately affect pharmacies where staffing shortages are already a challenge. Instead of enhancing care, this legislation may reduce access by forcing closures or limiting services due to infeasible staffing mandates. I urge the board to consider a more flexible, technology-informed approach that supports innovation, protects patient safety, and respects the evolving role of pharmacists. Let's work together to elevate our profession, not restrict it. Thank you for your time and thoughtful consideration.
Thank you for your comments. All right, let's move on to our next public speaker, public member.
Andrea Adams.
Hi, good morning.
Good morning.
Sorry, I had a delay in unmuting. Good morning, board. My name is Andrea Adams, and thank you for the opportunity to speak. I am a practicing community pharmacist in Northern Nevada who has worked for 3 different retail chains over almost 20 years in pharmacy. I really appreciate that the board is focused on safety and working conditions, but I feel that the proposed regulations will negatively impact patient health and welfare in the state of Nevada. I have concerns regarding many sections of this proposed regulation, but I do want to address 4 major concerns that I have. My first, and all of these have been addressed already, but I just wanted to speak up as well. My first concern pertains to section 2, subsection 1. I agree with CVS that this overlap needs to be by the week and not by the day. I agree with them that 80% seems very high and will likely require all retail pharmacies to hire additional pharmacists. My concern is that this is not a sustainable business model for most pharmacies in our state. We are already facing a nationwide pharmacist shortage and smaller pharmacist graduating classes every year. In Northern Nevada and our rural areas, it is extremely challenging to find any candidates applying for our open positions. And I fear that these staffing requirements are going to make that even more unattainable. My second concern is in regards to section 2, subpart 4. I agree that the 100 prescription pharmacist limit seems extremely low and is really lower than what I see dispensed at most low volume locations where I've previously worked. I can't say that I have the perfect number, but somewhere in that 300 to 500 range that has already been thrown out. Those are numbers that I have dispensed as a single pharmacist over the course of an 11-hour day. And I have to say, I never felt stressed or rushed, and those numbers felt very doable for me to achieve as the only pharmacist working with technicians. Technology has brought us a long way and enables us to dispense a lot more prescriptions nowadays than what was achievable 20 years ago. My third concern is regarding section 6, requiring pharmacists to document why a prescription wasn't filled in 72 hours. As you guys are well aware, the business model of pharmacies is we make money by filling prescriptions. So there is no pharmacy that wants to leave their prescriptions unfilled for 72 hours unless there are factors that prevent them from doing it. Forcing the pharmacist to watch for the 72-hour mark and document the reason is really adding to their regulatory burden, increasing their stress, and taking away from time they could be helping patients instead. My third and major concern is section 2, subpart 3, requiring a designated pharmacist for non-dispensing services. I fear that this will negatively impact the health and welfare of the public, particularly in our rural and underserved communities. As pharmacists, we want to take care of our patients and their health, and having the ability to provide life-saving immunizations anytime the patient is in the pharmacy, and as we're allowed by our license and by the law, is really critical to healthcare access for both our underserved and rural areas. I'm very concerned that this regulation will result in reduced access to healthcare across the state of Nevada. Thank you for your time today.
Great. Thank you for your comments. All right. Next,
Jenner Tahira.
name
You
sounds
know
so
that name.
familiar.
You're unmuted.
Good morning. Thank you for the board staff and for the board members for all your work on this matter. I would just like to say something about the ratio for particularly in multiple in pharmacies wherein there are multiple pharmacists. If what happens when during a shift, if one of the pharmacists leaves early or someone calls in sick, and then the ratio becomes out of the 3-to-1 or 4-to-1 ratio if approved, will we be given extra time to find a pharmacist to come in, or will we be forced to have our technicians leave the pharmacy? Thank you.
Thank you for your comments.
Next is Lisa Momodu. Right. Oh, you're muted. Let me try to unmute you again. You just need to unmute your line. You're unmuted.
Can you hear me?
Yes, we could hear you now.
Very good. Good morning, Madam President, board and colleagues present. I believe that this is a good starting point. My name is Lisa Momodu, by the way. I have worked at chain pharmacies, and I'm now the owner of an independent pharmacy. So I would think that for the pharmacists at the chain pharmacies, this is actually helpful, especially for pharmacies that have about 600 scripts per day. It is not easy, and this could be helpful if they're filling about 300 or verifying 300 in addition to their other activities. This is actually helpful for the pharmacist. So this is a good starting point. And this is typically for large chain pharmacies. And they are able to pay for 2 pharmacists. So I think this will be in their benefit. On the other hand, independent pharmacies, some of them do about 200 a day. So if 300, if you're requiring them to have 2 pharmacists, then each person is now doing about 100, 150. And we have to also do a comparable pay for the pharmacists to keep them. This would become a very uneven playing field, an unfair comparison, and eventually put a lot of independent pharmacies out of business. Independent pharmacies are able to provide this personalized service that chains at this point are just unable to or are unequipped to provide at this time. Independent pharmacies would no longer be available for those patients who prefer their independent pharmacies. So again, I do thank you for that, this step that you are doing, but this said proposal could be more applicable to the large chain pharmacies who have about 50 stores. And of course, taking into consideration based on these conversations, their location. I do thank you for your time and thank you.
Great. Thank you so much for your comments today.
Okay. Next up, we have Roseman class again. Let me unmute their line. All right.
All right. Can you hear us okay?
Yes.
All right. I am Leanna Oswald, speaking as a licensed pharmacist in Nevada with 17 years of experience in the community pharmacy sector. I've heard some really interesting things today. I've read the proposal. We've had the students read the proposal and have had a lot of different experiences shared from many of our students in the classroom with technician experience and some of those that have no experience that now are kind of wondering, what am I getting myself into? And I hear the laughs going around the room. And I just want to commend the board for taking this action. I'm speaking in support of this proposed administrative code. And although based on some of the things that I've heard, I do want to share some perspective. As a pharmacist who has worked community pharmacy with a drive-through and then worked in the Target pharmacies without a drive-through, there is a dramatic difference in the feel when you have that extra access point and where you're being pulled as a one pharmacist in the pharmacy. And so as we look at the numbers that have been suggested here, increasing them or looking at when a second pharmacist may be needed, if there's additional access point where there's going to be 2 different areas that need to be counseled by one person, maybe that is something that the board could consider. Whereas if you don't have that extra access point, I do like where you've highlighted that a pharmacist could close an access point as well, as I think that could help keep people safe. I've made mistakes in the pharmacy. I have filled 600 a day by myself. I have filled 200 a day by myself. And in each of those instances, because I'm human, I have made mistakes. And in each of those instances, I've had technicians, interns, the general public, the doctor's office, the transfers, they all have to flow through me by myself. And I'm pretty sure many of my colleagues across the state have felt the same when you are by yourself in that pharmacy. And I can't say, like many that have already spoken, maybe 100 is not the right cutoff number. Maybe it should be 200 or 300. But when you start to get up there, as a pharmacist, we need more support. And so I am very much in support of what the board is trying to do here, and I commend the board. Thank you.
Great, thank you so much for your comments.
Oh,
One more.
More public comment.
Uh,
Holly? Holly, we're calling on you. Can you unmute yourself?
I'm here. Can you hear me?
We can hear you, but we can't see you, which might be your choice.
I don't, I'm trying. I guess you can't see me today, but thank you for the
Okay,
opportunity.
we can hear you fine.
Perfect. Thank you for the opportunity to address the board today. My name is Holly Prevo. I'm a healthcare supervisor with Walgreens. I just wanted to keep this brief and mention that I would like to address one of the comments made by one of our prior commenters online. You know, at Walgreens, we are one of the largest independent pharmacies. And as a matter of fact, we are all reimbursed the same, whether you're at a retail pharmacy or at an independent pharmacy. So, and both of us struggle with payment. There was a great article published by our chief officer, pharmacy officer recently addressing those concerns with reimbursement. And I would be happy to provide that to the board if so requested. Thank you.
Thank you for your comments. All right, thank you everyone for your comments. I think that was a very robust comment session, and as always, we appreciate the feedback from the public. With that, I'm going to close the period for public comment and move it over to the board for board discussion.
Can I make one comment?
Sure.
Sorry, just the record keeping. Dave Weiss for the record. Liz McMiniman from the Retail Association made reference to comments that she had submitted to you. I was unclear what that was because there were so many comments coming in. So I did talk to her. She provided comments back in March, which you guys have already seen when we did that meeting. But out of a courtesy to her, I've re-given them to you. There's a copy up in the up for the public, and you have seen those in the past. But like I said, for other people, I want to make sure you have all the comments. So.
Great, thank you. All right, so I'll turn it over to the board for board discussion. I believe Mr. Tomaso would like to start.
Thank you, Madam President. Before I begin my presentation, I want to make a couple of interesting observations of what happened this morning, everybody coming before us. Nobody that came before us ever addressed the survey and 100 or 1,000 remarks that were made by the pharmacists that work for the retail industry. That was never addressed. Was ignored. We'll get back to that. Also, not one person that opposed this regulation gave a reason on how adding additional pharmacists is a detriment to patient safety or does nothing to increase patient safety. We didn't hear any of that. My last observation before I begin my presentation is that, interestingly enough, nobody wants to add pharmacists. But everybody that came before us, or the majority of people came before us, they're good with increasing staffing. They're good with increasing technicians, but they're not good with increasing a pharmacist. But add three more techs, they're happy with it. Just putting bigger burden on the lone pharmacist. So those are my three observations on what happened this morning.
Thank you.
I'm not to begin my presentation.
Oh, certainly.
Now, I sat here for 2 hours to listen to all that. I'd like to have a say in this, Madam President, for this board. This is for this board and for the general public. The retail pharmacy executives that opposed patient safety regulation continue to give the same unsubstantiated, generalized, overbroad, and ambiguous reason for opposing the regulation. They do not provide any examples, proof, documentation, or viable solutions that address patient safety concerns, which are presented by their own pharmacists. Same retail pharmacy executives completely ignore the results of the survey that were enumerated by all the pharmacists that work in their setting. Some of the reasons that they've given today and in the past. They can't hire additional pharmacists because there aren't enough pharmacists available to hire in Nevada. There are over 3,000 licensed pharmacists in Nevada and only 500 pharmacies. The problem is that pharmacists are refusing to work in a retail pharmacy setting due to patient safety concerns and the chaotic workplace conditions. The survey, the same survey that they ignore, indicated that 30% of all pharmacists have left the retail pharmacy setting due to the safety concerns for patients and the unsafe practices that they are forced to follow. There's a decline in enrollment in pharmacy schools. This decline, according to the Nevada Pharmacy Alliance, is the direct result of retail pharmacy's workplace environment and their unsafe policies and procedures that placed a pharmacist's license, his well-being, and his livelihood in jeopardy. Nobody wants to get involved in a career that can cost them their future if they were employed in the retail industry. The patient safety regulation will cause cutback in services to patients. We heard that too. Again, they make this broad and general statement without any explanation or examples on how the service is cut. Whereas this regulation as written was designed to have complete opposite effect to allow more time for the pharmacist to better care for the patients by adding additional pharmacists and technicians for all non-dispensing duties, as well as providing ample time for them to fill prescriptions without the pressure of having to fill so many prescriptions per hour or face disciplinary action by the employer. How about this one? There will be unintended consequences. No explanation as to what these unintended consequences were, just simply unintended consequences. They also make the claim that 11 other states have increased the number of technicians that a pharmacist is allowed to supervise. What they failed to mention is that these 11 states, that the same states mandate that there must be sufficient number of pharmacists on duty to eliminate work overload on individual pharmacists, so they would have fewer errors and misfills. Here's one that they said, the so-called red tape, the administrative part, is imposed by the Board of Pharmacy, the Nevada Board of Pharmacy should eliminate the red tape that a pharmacist must perform. The so-called red tape is the record keeping imposed by the state law, not by this board. Since every single legal drug entering the state of Nevada is placed under the complete dominion and control of pharmacists for storage, inventory, and dispensing. However, if the pharmacist didn't have to keep such records, that would give the retail chain pharmacists more free time to fill more prescriptions per hour, which is the ultimate goal of chain pharmacies at the expense of patient safety. Here's the best one. The pharmacy board should allow pharmacists to make use of technology to cut their workload. This technology referred to here is a photograph of the outside of a prescription bottle, which was filled by a technician at one location and then sent over to a pharmacist at another location to verify that it's okay to give this prescription bottle depicted in the photo to a patient. First of all, the policy violates two state laws, NRS 639-252 and NRS 639-245. The retail pharmacy industry took it upon themselves to self-interpret the state law in order to cut corners and eliminate the requirement that a pharmacist fill prescriptions or must inspect that a pharmacist that fills prescriptions must inspect and verify the prescription filled by a technician. Secondly, the pharmacist has no way to look inside that bottle to verify that its contents are exactly what was prescribed by the patient's physician. Thirdly, this technology system was designed specifically to allow the pharmacist working in the retail setting to pump out hundreds of prescriptions over a given period of time by simply flipping through photographs of bottles. This assembly line production directly leads to errors, mistakes, and misfills, and places you, the patient, and the people in Nevada in extreme danger, as pointed out in a statewide survey of their own pharmacists. Fourthly, pharmacists have expressed their extreme concern that this verification policy risks their license and that it's an unsafe practice. And that's why they're looking elsewhere for employment, because it impacts their ability to make a living. Now, why did I bring up virtual verification with this reg? Just to let you know the extent that the retail industry will resort to in order to pump out prescriptions like a wartime assembly line without concern for patient safety. Why are we here today? We're here because a number of retail pharmacies refuse to change their policies and procedures that contribute to a chaotic working environment, which directly leads to errors, mistakes, and misfills, and puts Nevada in danger, Nevadans. Their stubbornness necessitated the Nevada State Board of Pharmacy to propose a regulation to establish standards for licensees related into staffing, supervision, duties of a pharmacy, duties of a pharmacist, and requirements related to the timing of dispensing prescription drugs and devices. All this we had to do in an effort to protect the general public. In formulating this regulation, the pharmacy board staff allowed the retail industry to inject their language, which you've been told appears in red, into the regulation to be considered by this board. In that language, the industry used the word staff, sufficient staff, pharmacy staff, no less than 15 times throughout their dialogue, but nowhere was the word pharmacist ever mentioned. The word staff could cover clerks, cashiers, pharmaceutical technicians, technicians in training. Adding any number of these individuals to their staff would always put the industry in compliance with this regulation without ever having to add an additional pharmacist. It's my contention that adding additional staff for one pharmacist to oversee and be responsible for would only contribute to more errors, mistakes, and misfills, which would place the general public in more danger than they were in already under the current policies. Not to mention that it's the pharmacist whose license is at risk and who must face discipline by this board, while the retail industry's business practices were the root cause of the problems and who then deny liability when that pharmacist appears before this for discipline. I've been a public member of the Nevada Board of Pharmacy for almost 6 years now. Throughout these years, I acted as a judge and a juror presiding over disciplinary hearings of a few hundred pharmacists that appear before this board due to their errors, mistakes, and misfits. The vast majority of these pharmacists seem very apologetic, truthful in their explanations, and accepted responsibility for their mistakes. When their punishment was handed down, be it a fine, probation, or revocation of their license, many of them began to cry. At that time, I was unaware of their emotional dilemma. As time went on, I began to notice that the majority of these pharmacists worked in a retail setting. During questioning, they all spoke about the extreme pressure they were under from being the lone pharmacist on duty, the metrics they had to meet, or the non-dispensing duties they had to perform, all while being solely responsible for patient safety. Not long ago, I read an article published in the USA Today newspaper that addressed this board was hearing from Nevada pharmacists during these disciplinary hearings. Just a couple excerpts from that. In California, 91% of retail chain pharmacists surveyed by the California State Board of Pharmacy said that they lacked the staff needed to ensure adequate patient care. More than half the pharmacists polled by the Kansas Board of Pharmacy said they didn't feel they could perform their job safely. The biggest reasons were a lack of adequate staffing and employer-imposed metrics, like filling a specific number of prescriptions a day or providing services to a customer within a set time. The Virginia Board of Pharmacy passed emergency regulations in September of last year, banning the production quotas and bolstered pharmacy staff. And they left these rules in effect until March of this year, until they could develop and pass permanent measures through their state legislature. Medication errors are a pharmacist's worst nightmare, a pharmacist told USA Today. They lie awake at night wondering if, in their haste, they made a mistake that might hurt or kill somebody. That's this board's consideration here. In Sarasota, Florida, a child overdosed on a newly prescribed anti-seizure medication after a pharmacy dispensed the drug with the wrong instructions on the label, a retail chain of pharmacy. The American Public Health Association Task Force on Pharmacy Medication Safety issues estimated that the U.S. pharmacies make 54 million dispensing errors, of which 2.3 million are potentially harmful. 2.3 million. In September of last year, the Nevada Board of Pharmacy suspended the license of 2 CVS pharmacists who accidentally gave a pregnant woman an abortion drug instead of a fertility treatment she was prescribed. The mistake, which was first reported by Channel 8 in Las Vegas, ended the woman's pregnancy. This board fined CVS $10,000 over the objections of their company attorney, who argued that CVS did nothing wrong. The only allegation against CVS, according to the attorney, is that they employed these pharmacists. No mention of the policies that did it. It should be noted that both these pharmacists that appeared on this said that they were under extreme pressure due to the policies that they had to fill so many prescriptions in a lot of time frame, and it contributed to that misfill that cost that lady her pregnancy. The Nevada Pharmacy Alliance published a list of states whose pharmacy boards took the appropriate action to protect the general public from the retail pharmacy policies by passing regulations to eliminate quotas, understaffing, and help treat the mental health problem that these pharmacists are having. And these problems were caused, according to these pharmacists, by the policies that they're having to follow. The list included California, Illinois, Kentucky, Ohio, and Virginia. Nevada is last to get on board here. Nevada has got to get on board. We're the last. 15 other states have already taken action. We've done nothing. In early 2023, I approached Executive Secretary David Wiest, and I asked him if I could possibly work out with the executives of the retail pharmacy industry, if I could talk to them and see if we could get them to take a look at their policies and procedures and hopefully get them to make some changes that would cut down on errors and misfills. Mr. Wiest advised me that over the past 2 years before that, he and his assistant Yen Long had numerous meetings with the industry executives in hopes that they would self-correct the problem. He explained they refused to budge or offer any viable solutions. I didn't believe him. I asked if he could possibly set up another meeting so I could speak to them myself. Mr. Wiest arranged for me to meet with a retail industry executive. At the outset of the meeting, the executive, I asked him if he could work out some changes to the policies that would keep this board of pharmacy from having to take action and still result in patient safety and care. The executive leaned over to me and says, "We're never going to hire any more pharmacists." That was the opening of our negotiations. He said, "We're not going to do it." He went on to say that the only acceptable solution that the retail industry would agree to is for this board to change the laws to increase the number of pharmaceutical technicians a pharmacist could supervise. Just what I said earlier. They'll take on 3 more pharmaceutical technicians, but will they add another pharmacist? No. At that point, I realized that they were not negotiating in good faith, and the industry had no intention of working with the Nevada Board of Pharmacy. The executive told me, well, their chain made significant changes already to their policies. Like they gave pharmacists incentives to increase their work production. They increased their wages. They assured they get proper lunch breaks. They get rest breaks. And they give them more technical support and streamlining how they fill prescriptions. I attempted to explain to him that these changes didn't address patient safety issues. They just merely improved working conditions in the pharmacy itself, which should have been the case all along. That's what the problem is. The pharmacies are under duress. The pharmacists are under duress. It's a detriment to the patient. This technical support referred by this executive is a policy that is, by the way, is in clear violation of state law. They were having their pharmacists supervise more than 3 pharmaceutical technicians, which is the limit allowed by law. And all they had was these extra technicians change their code here, their name tag to cashier or clerk. The streamlining is another policy that is in violation of state law, which states the pharmacist supervising pharmaceutical technicians who fill the prescription must verify the selection, dosage, labeling of the prescription, and must inspect the final product. I spoke about that earlier. They had this retail chain had their pharmacists flipping through prescriptions filled by technicians and called that photograph the final product. And they said, this is technology. The photograph was invented in 1826, 200 years ago. Do you think that the legislatures that wrote that law 30 years ago didn't know that when they said inspect the final product, they could have said, oh, or a photograph of the final product. They knew photographs existed. That was the technology. They didn't say that. CVS self-interpret this. Other retail chains self-interpret laws. Even though I seem to have reached a stone wall in dealing with the retail industry executives, I still felt board action was the last resort. Regs were the last resort. I still felt that. Unless we were absolutely sure we had no other choice, and we were sure that board action was necessary to accomplish our mission and protect the health, safety, and welfare of Nevadans. So therefore, the decision was made to survey every active pharmacist in Nevada and make the survey anonymous in order to guarantee truthful answers. The hundreds of pharmacists were surveyed, hundreds of responses were received. 187 pages of data were compiled. This is the survey. That wasn't addressed. The responses were broken down into 3 categories: retail chain pharmacists, institutional hospital pharmacists, and all other privately owned, independent. As you'll see, the survey was not directed against the retail industry, but designed to elicit a response from the pharmacists who are in the best position to help this board accomplish their mission. The most disconcerting of the answers was, and you can look at yourself. If there's one there, I think Mr. Weiss says there's a copy up there. Question 36. What is the average number of medication errors that leave the pharmacy, if any, do you believe occur monthly at your pharmacy practice setting? Retail chain pharmacies, anywhere from 977 to 2,111. That made it out. Question 40. In your opinion, would an increase in the number of pharmacists in your primary practice setting affect patient safety? 93% of retail pharmacists said it would improve patient safety. Question 32. Do you feel that you have been pressured by your employer or supervisor to meet standards or metrics that interfere with patient safety? 86% of retail chain pharmacists said it interferes with patient safety. It's in here. Question 29. In your opinion, how does completing non-dispensing services while also engaged in processing prescriptions affect your ability to practice safely? 82% say that it diminishes their ability to practice safely. The same survey contains over 60 pages of remarks by hundreds of Nevada pharmacists asking, begging, that the pharmacy board help them keep Nevadans out of harm's way by giving them the opportunity to improve patient safety. This pharmacy board is the largest of all boards and commissions in the state of Nevada. It has thousands of licensees. That include pharmacists, doctors, nurses, wholesalers, pharmaceutical technicians, and pharmacies themselves. Keep in mind that all legal drugs that shipped into this state are placed in the hands of pharmacists who have the total dominion and control over the billions of dollars worth of prescription drugs. The pharmacists are responsible for the storage, inventory, and dispensing of these drugs. That's a pretty good responsibility for our pharmacists. The Nevada Board of Pharmacy is solely responsible for regulating and overseeing the pharmacy industry. This board staff that sat here before us today, they work with the FBI, the Nevada State Police, the DEA, local sheriffs and chiefs by discovering narcotics violations and then accompanying these law enforcement agencies on raids and act as their expert witnesses at trials. They play a big part. The Nevada Board of Pharmacy is the only thing that stands between the proper distribution of narcotics and dangerous drugs to the general public and the extreme physical harm to Nevadans. I'm going to say that again. The Nevada Board of Pharmacy is the only thing that stands between the proper distribution of narcotics and dangerous drugs to the general public and extreme physical harm to Nevadans. This board is the last line of defense to keep the public safe. That being said, it appears that we're back here in the same place we were over 2 years ago when representatives of the retail industry complained to this administration about the fines that they were given by the board, that the board was not in favor of technology, how this board is too strict, how they would like the retail pharmacy industry to appoint more retail pharmacy people on their board. None of this is true. None of this. We were instructed to be by the administration to be friendly and try to work things out, which we did. I've been doing it for 6 years. Mr. Weiss and Yen has been doing it for longer. After numerous meetings, nothing's changed. In fact, they made additional demands. The retail industry made other demands of the pharmacy board. Change the state laws to allow them to operate in a manner that is detrimental to patient safety. And as an example, Mr. Weiss just handed this out to every board member and put it up there for you to look at. This is a change in 21 laws. If we were to change these 21 laws in these states, everything would be fine. They could do whatever they want. The retail industry could do whatever they want. And it puts the patients in more danger than they're in now. Take a look at it. The major problem that this Nevada board, that each one of us have, the major problem we got right now is that the results of the survey, which we have, over 90% of retail pharmacists have claimed that these policies and procedures have been placing the patient and the general public in danger of dispensing errors and misfills. They tell us that. The people that are filling the prescriptions tell us the general public's in danger. Simply put, this board now has foreseeability. And if it fails to act and tragedy results, the repercussions are indefensible. In this court of law, the judge will recognize that if you have foreseeability and did nothing to prevent it, you're liable. Over the last year and a half, the Las Vegas Review Journal, Channel 8, and the USA Today newspapers have all done stories or articles about the Nevada Board of Pharmacy on how it was protecting the general public. But now should a tragedy strike, who would explain how this board allowed the retail industry to violate state laws and ignored the pleas of pharmacists who warned us that the safety of Nevadans were in danger? It would be much easier to defend the tragedy if this pharmacy board took all the necessary steps to try to prevent it than to try to explain why we sat back and did nothing, knowing full well that the retail industry was violating state law and a tragedy was foreseeable. The resulting civil suit would expose the state to extreme liability based on the failure of this board to act. In July of this year, at the pharmacy board meeting in July this year, a retail chain pharmacist appeared before this board for discipline due to a misfill of a prescription for a 3-year-old, which called for a dosage of 1.8 milligrams. The tech wrote 18 milligrams, and the pharmacist missed the error. A board member, actually the president, asked the pharmacist if he could explain what happened. How did you miss that? 1.8 to 18 milligrams on a 3-year-old? The pharmacist said his exact words, quote, "It was the busiest time of the year. I was the lone pharmacist. We were understaffed. I was working too fast." This industry has been slow playing this board for 6 years to the detriment of Nevadans. Thank you.
Thank you, Mr. Tomaso. I think your feedback and your perspective as a public member is highly valued. You represent the general public. And I think a lot of what you said shows your commitment to patient public safety in Nevada and is squarely in support of our mission statement. This is Helen Park. Just want to make a couple comments and I'll certainly turn it over to other board members.
Sorry, Madam Board. I think just to kind of, and I appreciate everything said. I did just because the Barracuda is on high alert, I did have one more public comment that I just snatched out of our safety net for emails. Laura's ready to read that in. I just want to be able to have you guys have your part in this. So we do, I think it's wise to read it in. I don't have the ability to print it out. Do we have the ability to print it out if I send you? Okay, never mind. I will let you keep going. We'll get it printed out and then you'll have it. So that'll be perfectly fine.
Okay, great.
I sent it to you a while ago. Okay, thanks. Sorry, Madam President.
No problem. So one of the things I just want to emphasize, and I know that Mr. Weiss mentioned this earlier on as well, is there is a problem, right? I think all of us across different practice settings, across the industry, recognize that there's a problem. There's a risk to patient safety due to the staffing levels. And that understaffing has contributed to medication errors. It's attributed to, or it's led to burnout and stress of pharmacists. And that in itself leads to more potential medication errors. And so the survey that we sent out to all of our licensed pharmacists was a way to receive input from all of you, right? All of you out there, who many of you have said that you were scared to provide feedback because of potential, retaliation or retribution from your current employers. So with that, we sent that survey out. We allowed that input to come in with protection and anonymity. And with that, I think we got a lot of meaningful feedback from our pharmacists out there. So I really appreciate those who responded to the survey, who shared with us what the working conditions are like, who have candidly shared with us that they feel that they are in a risk or they're posing a risk to patient safety due to their lack of staffing. And that they share these things despite, concern from their current employer. I also want to thank those who came today in person and online and shared your feedback with us as well. This is a very complex issue. I think there's a lot of different stakeholders and things that can that are kind of in play here. But the bottom line is that there's a risk to patient safety. There's a problem due to staffing, and we are here to help to address that issue. That is our job as the board, to protect the public and to ensure that the regs that we have out there, the laws that we have, make it that it's a safe environment to improve patient safety for all of our pharmacies across Nevada. So I just want to kind of recenter that we are here to help, right? And we appreciate the feedback that you've given. There's a problem, and we're here to attempt to address it through our lawmaking process. And we're doing that collaboratively as a group, so I appreciate the feedback. I'm glad that our board staff has worked with members of the public, with the Retail Association, with other industry leaders, and pharmacists have come in. That being said, the survey results were very clear. So on behalf of the pharmacists that responded, 74.6% of retail chain pharmacists said they are not sufficiently staffed. 68.3% said that they feel that their current staffing poses a risk to patient safety, and that for additional staffing, the top answer was that they would like to add an additional pharmacist. So the language that you have in front of us is a reflection of what our pharmacists have asked for. And not only is it what the pharmacists have asked for, but also includes feedback from other stakeholders in regards to how we can all of us, improve patient safety through workplace staffing. I've listened to the feedback from those of you today, of course, and then also feedback that have been sent in via email, feedback outside of this board meeting. And I think that the regulation that we have and the wording that we have in front of us, that there's a lot here that will make the workplace safer. I think that there's certain areas that I may be open to modifying, or, I may be open to modifying, and maybe the other board members would be as well. Particularly to support our rural and independent pharmacies. But I think that it's important that there is some level of pharmacist overlap. I'm hearing from public comment that there's so much more that pharmacists are doing, that they're providing more clinical services, that they're, working and providing long-acting injectables, that they're working and they're providing contraceptives. That's wonderful. But to me, that also says more and more on their plates on top of, vaccines and dispensing without the adequate, overlap or support. So for those of you working in a community setting, I appreciate what you're doing, because you're doing so much with so little. And this reg could potentially help in terms of adding that support that you need in order to do the job at the top of your license adequately and safely. So I think I'll pause there and then turn it over to some of my other board members. I'm in favor of the reg. I'm potentially open to changing or modifying some components. But I think it's important that we answer this call from our pharmacists and mostly, to ensure that we address that public safety risk.
I agree with you, Madam President. I'd even be open to some changes, but there has to be something done with this reg or the one we looked at previously, because how could we as board members sit here and discipline a pharmacist that appears before us if we don't help him, if we didn't give him the tools and help him what he begged us for, we don't give him that help that he begged us for, how could we discipline him? We got to be able to say, listen, we did what you asked. We gave you an extra pharmacy, we gave you this, we did that, we lowered this, we lowered that. And you still made a mistake. Okay. But if you do nothing, if we don't help him, how can you discipline him? You can't.
All right, so board members, let's start. Crystal, Ms. Freitas?
So I won't talk as much. In general, I am in support of the regulation. But it was very evident to me the trend that was appearing before us in all of the testimonies and public comments we have heard today and have in front of us, that the staffing is a major concern in both retail, major chain retails, and in the smaller independents in the rural areas. My struggle with this regulation has always been to how to separate that when they're all considered retail. I think after hearing most of it today, saying how it would hurt some of the smaller pharmacies in rural areas, they thought it would close their pharmacies. They thought it would limit the access, which we don't want, which would have the opposite effect of what we do want. I think, in my opinion, pharmacists, we are smart. We've done a lot of schooling. We're very educated. We're able to make competent decisions. I think I might be more in favor of putting it onto the pharmacist who is staffing, or the PIC, they're pharmacists as well too. So letting them be able to determine how to safely and effectively staff their pharmacy to be able to handle all the services, which kind of leaves sections 4 through 5 alone, saying that they can limit services as they feel needed. But I think if that's the case, I would feel like something about retaliation on the pharmacist who decides to limit that service or access point would be needed. Because right now it just says retaliation on, the pharmacist for all of these things. But I think if we're going to do that, it would be, if the pharmacist decides, hey, I had a call out, like Jenna Tahero had spoken earlier, I had a call out, I have to decide now what I'm going to limit. A pharmacist should not be retaliated against if they decide to limit immunizations for that day for that reason. But I think a pharmacist should be able to make that decision if I am safely able to dispense all of these prescriptions. Yeah. So same thing with metrics. If they were not meeting the metrics that corporate pharmacies impose on pharmacies for deciding to not offer a service or limiting an MTM service for that day or whatever it is due to their staffing levels, they shouldn't be penalized for that. So that kind of puts it more back on the process. Yes, I agree with all the process, putting a process in place. They should be able to report, I'm not safely staffed today. And then it's up to their employer to make sure that, ensure that that happens. And then it kind of puts it back on the corporations or the larger pharmacies. Because I don't feel like the independents feel like they're short-staffed. I think they feel like they're able to staff appropriately. So just kind of my thoughts.
Okay, thank you. Thank you for sharing your feedback. I think just one point I wanted to mention is your comment on, we should have maybe the pharmacists are capable of making those decisions. They're very competent in that. I agree, right? Absolutely. But, it's followed with, and if they do, that they're not retaliated against. And I think what that shows is underlying, there's a strong pressure on the pharmacists, even though they can, not to do what they need to do because there's a fear of retaliation. And when that happens, then the pharmacists, even though it says that, may not feel comfortable because they may face that retaliation. And I think that just means in order to ensure we have that safe environment, we have to put something in here that spells it out, so it's not all on the pharmacist. If you say, you know, the pharmacist can decide, that's great, they're, you know, capable of doing that. But if they do, to your point, they are likely gonna have to have some protections. So to me, that means that they need support through our language that doesn't put them in that position.
I just struggle with how do you compare a chain retail pharmacy with 57 locations in Nevada versus a family-owned retail pharmacy in rural
Agreed.
Nevada. So it's because you can't apply the same rules to them because they may not be able to survive. Maybe they're the only pharmacy. We've done that before where we have new pharmacies or ownership changes, and they're the only pharmacy in that area. So if we put a same limit on them and they're not able to meet it, and then we cut off that service, what happens to the patients in that area?
So I think on that point, you know, and I mentioned that in my statement too, is I'm open to potentially changing some of the language to support the rural pharmacies and independent pharmacies. I think it's different enough where, you know, we can ask board staff to help us create some type of language that does that, right?
Yeah, because that's always been my struggle. I don't know how you can differentiate in law retail, independent, you know, rural versus retail chain.
There's multiple ways you already do it in law. So, I mean, if that's the direction you want to go, staff can do it. We've had different compounding regulations for people that were in the rural. The rural is kind of already defined in state language. CRNAs can do different things in a rural than they can do in a metropolitan area. So if that's the path you want to go, that's fine. I think the other thing too, just because we're having a little bit of a dialogue, you're limited by the punishment that you can give. So we are not the Labor Commission. So we do not have all the tools that the Labor Commission. So the retaliation might be a thing, but that's a $10,000 fine is where you kind of end up on that. Obviously a revocation, but that's a big deal to do, you know, because then you're affecting all the patients and everything. So I think it's a great dialogue, but, you know, I just want to, you know, give you feedback. You can ask Yen and I questions or whatever you want to do. Which
Crystal, getting back to your independent pharmacies, I agree. I agree with you. Yeah, I wouldn't want to hurt our independent pharmacies if they're doing the right thing for our patients. But in this survey, when you talk to independent pharmacies, they're not having any issues. They don't have the volume. They're not pumping out thousands of prescriptions.
Right, but they're still.
They don't have the issues that the retail pharmacist is having. And they're really not, and like Dave said, you could probably carve out something for them to protect them because they're not having the patient safety issues that we're having in the retail chain.
Right. So that's what I'm saying, because it says retail right now, but there's no delineation between those.
Yeah, again, for me, we can do it two different ways. We can, you know, and they're carved, it's all throughout the language of how many employees you have, how many locations you have, not just for pharmacies, for other businesses. So the language is out there. I think the other thing, and again, I think that you're going to say, move forward with something and you're going to give us some recommendations that we're going to go work on the language and then we'll have another workshop. It sounds like that's where we're heading, which is great. The number of prescriptions would also determine that, because if it's 300, you've heard people say 300, you've heard 500 or whatever. So you can also deal with them with the number of prescriptions. I think that we'll have some thoughts about what they said, the differentiation between pharmacy non-dispensing and dispensing. So all those things, if you give us some directions, I think we'll be able to bring you back a document that will address the things that all throughout the process, you've been trying to address what has come in front of you. I've done it, so I know that, but you can't address everything. So I'll turn it back.
Right. Well, I'm the public member, as I told everybody before. I've never filled a prescription. I've never worked in a pharmacy. I bow to my fellow board members to, if they want to think that the percentage, the 80% was too high, 20% is a little low. But if they think that's high, okay. I think the public could still be protected by lowering that a little. I think that you could even raise the number of prescriptions that would help an independent pharmacy. Like I say, I'm not a pharmacist. You would know it. You would be the person that has to do it if you were in the retail pharmacy industry. Even a carve out, even the 72-hour limit, Somebody made a good point about that. Because you would know, you board members know that, I don't. Changing weeks to days or days to weeks, that would be part. Whether or not to include the interns, like they brought out from the thing. You would know better than I would. I'm open to it, except I'm saying that we have to do it right and help protect these pharmacists that are gonna appear before us for discipline. We have to help them. You can't just leave them out there. We can't, a tragedy can't strike us. So I'm willing to do whatever you as pharmacists say. And I'll go along. I'm not gonna fight it because you know, but we have to do that, and it has to have teeth. Otherwise it's no good. We wasted our time there. It's gotta have teeth. Thank you.
Sorry, so one more thing to just,
Yes,
he brought it up, the interns and staffing too. I think that wording, maybe excluding them not as an and, but like an or, you know, because I agree with what that P1 student had
I
said.
agree too,
Yeah.
and I think we should likely exclude the interns because otherwise
Something like an
their
or, maybe not
purpose
an
there
and.
is a learning experience, not to.
As a fill machine.
Yes.
Right. And then the transparency and staffing, I heard that earlier too. That's something I'm in favor of as well. Maybe not in this regulation, but
What does that mean? I don't know what that means.
well, how they calculate staffing budgets,
That-
I'm interested in that.
That will be a difficulty to get.
Yeah, no, but I'm just saying like that is something, once they said, I was like, oh, I've never thought about that, but that's a good point. Okay.
Well, thank you for your points. I think that they're good too, and I think for independence rules, that we could potentially do something to support them, with this reg.
Adam, for the record, I do have a few general thoughts and then I have some pointed suggestions for language improvement. So I think in an ideal world, we could just have sections 4 and 5 and the managing pharmacist would be able to staff their pharmacy with whatever they wanted to do, whether that be a pharmacist or a tech or an intern. But that's just not the reality of community pharmacy today. We know that. We've heard, that there is resistance specifically to adding pharmacists staffing. And so I do think that some form of section 2 in this regulation is absolutely necessary to define what are the ground rules and go from there. And so the other thing that I would say is that, I have 3 outpatient pharmacy locations that I oversee, and they range in fills from 700 to 800 a day at my busiest store to our newest, smallest store. They're lucky if they're doing 150 a day. And so our staffing is all over the place. We have one pharmacy that has 5 pharmacists in the pharmacy at any given time. And then I have one that has 1 most of the time. I do have a 24-hour location. So I am sensitive to, what that looks like. So section 2 in some form in my mind has to stay. The specifics of that, I really struggle with this concept of if you're a busy pharmacy, you have to have 2 dedicated to dispensing and 1 dedicated to non-dispensing. The non-dispensing person can shift back to dispensing if necessary. I think that might be a little bit of overkill. And just frankly, I think saying that if you're a busy enough pharmacy, whatever that threshold is that we decide, that having 2 pharmacists and those 2 pharmacists can figure out between the 2 of them what they can and can't do safely based on what's in sections 4 and 5. I think that is a really good starting point and would be a huge improvement to patient safety in our state. So I would like to see specific suggestions I have. Section 2, subsection 1, references to volume, I think should be changed from daily to weekly and adjusted. I think that we should strike the language that says who are fully dedicated to dispensing services and just leave it at if you meet whatever threshold it is, you got to have 2 pharmacists. I would strike subsection 3 that talks about specifically the non-dispensing services as a separate issue. I would amend subsection 4 of section 2 to something higher than 100. I think we've heard today that specifically for independent pharmacies and rural pharmacies specifically might be an issue. And so, you know, if that's 200 a day, 300 a day, I think to be determined at this point, or if it's 1,400 a week, so that there's some allowance to the weekends are slower, and you could maybe staff less. If we're saying 80% of the week, that gives you a little bit more flexibility and from your staffing perspective to say, I'm going to have more on the weekdays than I'm going to have on the weekends. I would strike section 2, subsection 5, because it's not necessary if you don't have subsection 3. And all of this is predicated on if the pharmacist, through the ability within section 4 of this proposed regulation, has the ability to limit access points, has the ability to say, you know what, I can't do an immunization right now because we're just too busy doing other stuff. You're going to have to make an appointment. That all makes sense to me if you have those two people to support each other, let alone that they can, I mean, just to get a bathroom break independently, be able to take an uninterrupted lunch period. I mean, you really need to have two pharmacists in order to do that. I think we heard a lot about the impacts of section 6, specifically subsection 2 of section 6 and the documentation. So I would be open to striking subsection 2 of section 6. And I thought it was a really interesting point that was brought up about the role of interns in these ratios. And so the way that I look at it, I guess, is that the way that interns function are very different if they're on a school rotation in a community practice and what the expectations of that are versus if they're a paid intern that is working for the company. So I think that in my mind, you would want to include paid interns in the ratios because they are really functioning as in the dispensing roles, as opposed to if we had a way that we could kind of carve out students that are on rotation. I think that would be beneficial. So that's pretty much everything I have.
Yeah, we can do whatever you want. Can I just ask Adam a question? And again, no decisions, but I'm just going back to Dick's survey. So there's definitely there's a point with the cognitive stuff. So I understand your point of not getting to 3. Would you be kind of open that there's 2 entry points into the 2, meaning that if you're filling a moderate amount of prescriptions, but then you're doing a moderate amount of other things, that brings the pharmacist in. And then just the sheer numbers brings the pharmacist. So you're limited to 2, but there's 2 entry points for that, if that makes some sense.
I think my concern is that gives people an excuse not to do those things. So I think if the limitation is, you know, we want to have as many pharmacies in this state as immunization access points. The last thing I want is to say, I have to make a business decision because we're filling 200 a day and we don't want to staff another pharmacist in order to do those immunizations. I think that if you have 2, you're going to be able to do those things.
No issue with that. I'm going back to the survey where like one of the big points of the survey, and I just want to do it in front of the public, is that the extra stuff that you're asked to do is a major problem. And so if you just remove that completely, then we're not, and that's to your choice. It's not going to be my choice. I'm just trying to frame how I'm going to write it up. And I think every point that you see, but again, I'm just going back to the survey, that the extra stuff that the pharmacists are asked to, I mean, since we're doing some anecdotes, every time we have a new thing that pharmacists are allowed to do, I get calls, you're killing me. And why did you do that? And they like it, but they're just asked to do it. So I think that we'll contemplate it. We'll bring that back. I understand. I clearly written down what Adam is talking about. I'll try to see what we have 4 board members. So that's the point.
That was question 29.
Yeah, thanks, Dick. It's bad, I know.
Completing non-dispensing services affects your ability to practice safely. 82%, as it does. That was the other disconcerting the questions. So it is there.
I think it's meeting.
You know.
Yeah.
The metrics of meeting those other non-dispensing services, I think that's putting the pressure on them.
So that brings up my biggest question. Have we ever talked as a board about limiting those metrics or quotas or things of that nature. Other boards of pharmacy have done that, and I was just wondering, I know I'm a newer board member, so I don't know historically what's been talked about or discussed. So
I can address it if you want. So I think that that could be done. It's been done in other states. I think the issue that I've seen in other states is what's a metric? How do you define it? It's a performance thing. It's something other than that. And so I think that the board's intent with back when we talked about metrics, but when we got to the survey was if you fix what the problem is, you don't have to.
You don't have metrics.
We had a language that said you can't do metrics. But that got put out because if you fix the underlying problem the best that you can under your authority, metrics don't matter. So that's kind of where we are today. But we certainly can put, if you want to say you can't do metrics, that's fine. It's just, what is a metrics? And I have metrics on me. Like if I'm not doing my work and getting it to you on time, you are not going to be happy with me. So like the metrics to me have a role in certain circumstances. And so to say you can't do any, I think would be hard. But I understand the point.
But you know, the reg, not this one, the previous reg that the retail industry didn't want to work with us on, it was baked in. It was, if we can't agree with, if they can't agree with us on this reg here, the other reg, it was based on volume. It's baked in. Metrics are baked in. In fact, it carved out independent retailers because they didn't do that volume. They weren't even in that low. But then if they were in that volume, then yeah, patient safety is a concern. You better put on another pharmacist if that small mom and pop thing was knocking them out like a wartime assembly line. So that other, I mean,
And it's still alive, as Dick's pointing out. So
that was, everything was answered. Every argument was answered in that previous one. It got substituted with this one, but it doesn't look like this one could be worked out either, but I just want to say, we couldn't go back to that.
yeah, we can, Dick. Sorry,
Anything-
Anna.
No, what were you gonna say?
Just if you had any other.
No, I just, I know that a lot of the public comment focused on utilizing technicians as the solution. And while I want to acknowledge how valuable technicians are, I also want to remind pharmacists, and those that are not pharmacists here, how difficult it can be when you have 4 or 5 people talking to you at once. So that doesn't necessarily minimize the distraction that would potentially lead to error. As I've worked in retail my entire career, I've seen errors. I've been involved in errors. It's a terrible feeling. And so I do think that this regulation is important in order to protect patient safety. But I'm also open to compromise. One of the compromises that I was wondering if was possible, in order to help protect the role of the technician and to acknowledge their role within the delivery of clinical services, is to potentially include language in section 2, number 3. We are talking about the addition of a pharmacist for non-dispensing services. Is there ability to add language, or would it make sense to add language that technicians can be included if they're able to provide that non-dispensing service? So particularly immunizations. I don't know if it will ever be included in the Nevada law to allow technicians to do things like the blood glucose or the swab testing, in addition to helping the pharmacist. But if and when those regulations do change, would a technician be able to be included in that, just to increase the ability to offer those services? Because my concern is I don't want pharmacists to be unable to do that, or to be refusing to do it based on staffing. And that would help increase access, but also increase the patient safety of not having, the pharmacist be the only one able to provide those services.
All right.
Zoom.
So if we have Shanice Taylor or Jay Jacobo.
I'm here. I've been listening to all of the comments, both from the public, from other pharmacists, our public member, and I really appreciate all the perspective. I mean, I don't want to beat a dead horse. I feel like this regulation is needed. I'm open to amending, several of the provisions. I agree with a couple of the board members. And I think, it's time for change, and we just need to come to the table with the solution that's going to help everyone, especially protecting patient safety and the public. So open to discussions and seeing any new amended language, just so we can come to a common meeting point and affect change.
Great, thank you. Right, Shanice Taylor?
If Ms. Taylor was booted off an accident. I do not see her currently. And she may be dialed in on a telephone, and that doesn't record the name, but right now I do not see her on Zoom. Shanice Taylor, if you're available.
Madam President, I think that if you just go back to finishing up your part, I'll try to get a hold of her, and then we'll just mark her not absent.
She's back.
She's back, okay, or not mark her absent, sorry, not absent.
All right.
She might have just had a technical issue. They're running around. Shanice, are you there?
She is, but you just need to unmute your line. She just logged in, so she may not know that she's being called upon. Dr. Shanice Taylor, if you can unmute your line, please. And she may be having some difficulty here, so let me make her.
She is a
Meeting.
Yeah.
Oh, wait. Ms. Taylor, Dr. Taylor, you just need to unmute your line if you want to make comment on this regulation. She has not.
I'll call her real quick. I'll just call her real quick.
We could circle back around. Mr. Tomaso, yes.
I'd like to ask somebody out there if you'd be willing to come up and just explain. I'm not trying to be a wise guy, believe me. I'd like to know why it's okay to add 6 techs for 1 pharmacist, put on 3 more techs instead of 1 pharmacist. Someone come up and explain why that's a detriment or why that doesn't work with someone. Why you're good with adding 3 more people to a shift, but not 1 pharmacist. If someone would just tell me that, if you got a legitimate or any reason. I'd like to hear it from you.
I did not realize that Mr. Tomaso was going to do this. So I will say, if you do choose to come up, your time will be limited to 1 or 2 minutes, just for the sake of, we need to keep moving. But if you do wish to respond to his question, you may come up, but your time will be limited.
Yeah, thank you.
Thank you, Board Member Tomaso. Rob Geddes with CVS Health, although I will clarify that this is giving comments from my own perspective, not from the comment perspective of CVS. I think for the most part, when you look at this, it really comes down to just the equation of what a pharmacist's salary is, and looking at the operating budget that a pharmacy would have. So adding for the cost of adding a pharmacist, generally 2 to 4 technicians could potentially be brought in to support that pharmacy. So it really just it's a math equation. And it comes down to the profitability of a pharmacy. We've had certain people talk about the reimbursement rates in pharmacy diminishing and continuing to do so. All of those factors combined makes it very difficult to foot the cost of an additional pharmacist, but we recognize that technicians can also still benefit the pharmacists to be there. I think that the conversations that I've had with some of the modifications are helpful, but hopefully that it comes down to the economics. That's really what it becomes.
And thank you for coming up and saying that, because I was curious.
Mr. Tomaso, thank you for the question, and just to address a little bit further, Lori Holmes again, Walgreens. I know you mentioned earlier in your testimony the number of pharmacists that are licensed in the state. We truly do not believe that there are enough to comply with the regulations as proposed. So despite being able to potentially, if we can't fill the number of pharmacists by at least adding technicians, technicians can support a lot of the work today. Our pharmacists spend about 40% of their time doing tasks that technicians can do. So if we were able to add additional technicians, which don't have to go through all of the rigorous doctorate level training that a pharmacist does, we can't just create pharmacists overnight. It takes four or more years to complete pharmacy school. So being able to add technicians to be able to alleviate some of the things that can't be done within their current scope would alleviate a lot of the burdens on our pharmacy teams today.
Okay, thank you. So your reason is because you don't think there's enough pharmacists. Okay, that's good. But just about a year ago, Walmart had an opening for a pharmacist. They had 40 applications. This is a year ago. Walmart in Las Vegas had 40 applications to fill one. So, and then you're trying to predict the future. You're trying to say there's just not enough. You don't know what's out there. You don't know. The board knows how many pharmacists are out there that are not working in the retail industry or not even working in the pharmacy industry. The board knows. And as far as your explanation, sir, thank you for coming up and saying that. My answer to you is, I understand it. I know where you're coming from, except this board cannot consider revenue. They have to consider patient safety. They can't consider what happens revenue wise. I didn't mean to open this up for everybody to come up.
Did you get your question answered?
My question was answered. We're done.
Thank you.
All right, thank you.
Okay,
All right, so I'll turn it over to, if Shanice Taylor, if you are online and if you'd like to comment on the regulation, I just wanted to give you, or the workshop language, I just wanted to give you an opportunity as part of our discussion.
I can confirm that Dr. Taylor is having technical issues.
okay.
She's been with the meeting.
Yes.
I'm only corresponding with her for the technical issue. I've asked her to log out and log back in one more time. It sounds to me like this will not be the last time we'll be talking about it. So we could probably pick it up at the next time. Or you might be graceful enough to let her do it at some other part of the meeting if you choose.
Someone mentioned yesterday, it's a tough month for techs.
Yeah, it is.
All right, so kind of bringing it back to our board discussion, I think based on the feedback from almost all of our board members that we are in favor of moving forward with the language, and we are open to a number of potential modifications. We'll ask board staff to help us with crafting that language. And that language would be to support the independent and rural pharmacies. I don't know if that's potentially.
I have it written down as you were all doing them, so we have to use the attorneys. We'll have to make sure Brett says it's within law that we can do it. It's still got to go to LCB and they're gonna change it. We're at the very beginning of a new process. To Tomaso's point, the other one's sitting there. It doesn't sound like you want to move with that today, but you could say that you do. So I think we're good. And we also listen to the industry, and I just think that there are obviously some things in the industry that won't affect the reg too much, and we could probably do. So we'll try to, like we've always done, incorporate all of the problems.
Excellent.
We have Anna's stuff too.
Okay, wonderful. All right, well, I appreciate the board's discussion on this matter, and I think ready to entertain a motion.
I don't think we need a I mean, you can do a motion if you want, but I think that Brett or Greg, do we need a motion or we're just? Yeah.
Okay.
Yeah, so I mean, you directed us, so we understand. We'll
Feedback.
do it. We'll try to hit the mark. If you want to do a motion, you can do one.
We don't need to.
Yeah, so I'll close this agenda item with saying that we really appreciate, again, the feedback from our public members, board members, members in the pharmacy community, our retail partners, our industry partners, and everyone who participated and collaborated to get to this point. So I think we're headed in a good direction. And thank you, board staff, for working on the language and continuing to work on that language. All right, and that brings us to 12 o'clock.
Yeah, we'll break.
We'll break for lunch and we'll reconvene at 1 o'clock.
1 o'clock. You'll see Mr. Hilby.
Okay, great. Welcome back to the Board of Pharmacy meeting. We're going to circle back real quick on 14B, the workshop item. Our board member, Dr. Shanice Taylor, had some technical issues and wasn't able to speak at that time, so I will give the floor to her for her comments. Oh,
Denise, you need to unmute yourself. We can see you. Looks good. We can see you. Let's get you unmuted. Dan's gonna try again, so just hold tight. Look on your side, the unmute button.
Okay,
should
are
be
you able
good.
to hear me?
Yeah.
Oh, perfect. Thank you. Thank you again, Dr. Park, for giving me a moment to state on what we've discussed so far. I don't want to take much of the time, but I do want to address my concerns. As mentioned, I do think it is a detriment for us board members to regulate staffing requirements for pharmacies and not leave it on the shoulders of the pharmacy managers and the PICs. In my experience, sound clinical pharmacists, they may not also correlate to, the business acumen and making those sound business decisions, especially if they're faced with peer pressure or, having retail chains highly regulate staffing requirements or their staffing desires for that matter. These retail chains, they predominantly hire on new grads, right? So they have that notion of naivety in the field and they can be persuaded and highly recommended to follow what these big corporations want. So I do think it's something that we should step in and regulate, especially given that we've given the opportunities and had the conversations with the executive corporations to make these policy changes on their own, and they refused. With Section 2.1, two staff pharmacists 80% of the time, I do agree with that. I am more sensitive to the requirement of 65% of having two pharmacists available in a 24-hour facility. I do think maybe that should be adjusted, just given the notion of the later hours and being sensitive to the slow workflow and that will occur during the later time of the day. As far as the comment or let me see where it was on 2.3, the non-dispensing services requiring an additional third pharmacist, I do agree that may be overkill. Two pharmacists, absolutely, with that decision not being regulated to have a third. I think that should be left up to the staff manager at that time. If they decide they need an additional assistance for the pharmacist, then so be it. But regulating that, I think, is a little overkill. In regards to the quantity that's written here, as far as needing two pharmacists, if it's less than 100 scripts in Section 2.4, I think that threshold is too low. If that can be readdressed, maybe increasing that threshold to 300 or more, having some type of commonality in regards to realistically, I would think 100 is something one pharmacist can do on their own. So I do think that's a little too low, as well as if there's less than 75 scripts processed, then that third pharmacist regulation is not needed or is not required. I think that number is also too low. Ultimately, if we would remove that requirement for having a third pharmacist overall, I do think this is something that we should not ignore. Pharmacists all around in retail in Nevada has made it very clear they're asking for our help. I think it is on our shoulders to listen to them, and it is on our shoulders to take this into consideration, just with a little bit of, amendments and adjustments to what has been proposed so far.
Great, thank you so much. I'm glad that we were able to get your perspective on the workshop language. And I know that board staff has noted that, and we'll take your feedback into the next iteration that they come up with.
Thank you.
Great, thank you.
Madam President, I just want to make the board aware that Jay Jacobo is not on the line, so she is not available and not present during this part.
Okay, all right, thank you for letting me know. Okay, we'll move on to our next agenda item. That's our final workshop item, 14A. I'll turn it over to Mr. Cant.
Mr. Weiss.
Mr. Weiss.
Thank you, Madam President. Dave Weiss for the record. I can promise you there will not be as much public comment on this as the last one. In front of you is a regulation that relates to an AGO that we got from the Attorney General. Brett is available for comments, but he's basically taking what that AGO says that we need to do for regulation and put it in front of you. So we can pause for any questions, and I will allow Brett, of course, to say whatever he wants to say about it, but we're just doing what we need to do to tidy up the law.
Brett Camp, legal counsel for the record. Just briefly, the Attorney General opinion brought some clarity to the issue of the authority of a homeopathic physician with regard to possessing, administering, prescribing, and or dispensing dangerous drugs or controlled substances. But the Attorney General opinion, while you're entitled to rely on it, does not have the force and effect of law. And so the benefit to this proposed regulation is it codifies as law the guidance that was provided to you through the opinion, and then you enforce the law. And so that's why we're proposing it. It's the next step in following up on the opinion.
Great, thank you. So with that, I'll open up the floor for any public comment on this workshop item. Do we have anyone here or online who wishes to make a public comment on workshop item 14A?
You have a caller on the line? Dr. Nario?
Yes, hi. Good afternoon, everyone. President Park, members of the Nevada State Board of Pharmacy, and fellow attendees. My name is Dr. Melvin Nario, VP of the Nevada State Board of Homeopathic Medical Examiners. I'm reading this letter, actually, as approved by our president, Dr. Bruce Fong, and on behalf of our board. Thank you for the opportunity to address this workshop and for ongoing dedication to protecting the health and safety and welfare of Nevadans, as outlined under NRS 639.070. I appreciate the board's collaborative approach in convening this discussion in LCB file number RO15-25, which seeks to clarify the authority of singly licensed homeopathic physicians to possess, administer, prescribe, and dispense controlled substances and dangerous drugs in homeopathic doses. As a representative of the Homeopathic Board, I would like to clearly articulate our board's essential regulatory role and longstanding expertise in homeopathic medicine, while equally recognizing the Pharmacy Board's statutory authority over controlled substances under NRS 639.233. The Homeopathic Board, established by NRS 630A.200, is charged with the licensure, oversight, and scope of practice for homeopathic physicians. This includes stewardship of the definition of homeopathic medicine as set forth in NAC 630A.014 and specifically in Section F, which states that pharmaceutical preparations may include narcotic drugs or opiates listed as Schedule II controlled substances, but only as recognized in the Homeopathic Pharmacopoeia of the United States, or HPUS, and prepared in accordance with the homeopathic standards. It's worth noting that the majority of our current licensees are dual license, with only a few being single licensees, meaning this issue primarily affects a small subset of practitioners. The AG opinion of March 26, 2025, opinion number 2025-01, provides further clarification of this regulatory landscape. It affirms that singly licensed homeopathic physicians in Nevada may only prescribe controlled substances and dangerous drugs strictly as recognized in the HPUS, and solely in homeopathic doses, such as serial dilution, such as 6C or 30C, and not in allopathic or pharmacological quantities. So this opinion rightly recognizes the Pharmacy Board's vital oversight to ensure compliance and public safety. But it also underscores that this system only works through effective collaboration between our boards, mirroring the intent of Nevada's dual regulatory framework. So it is also important to emphasize that any changes to the meaning or scope of the Nevada Revised Statutes, or NRS, or the NAC, in the Nevada Administrative Code, governing controlled substances or dangerous drugs must follow proper legislative or regulatory procedures. So the Pharmacy Board, Homeopathic Board, or any agency may only amend these statutes or regulations by presenting proposed changes through the established legislative process for the NRS or through formal administrative procedures for NAC including public notice, workshops, hearings, and final approval. AG opinions and board rulemaking cannot independently change the law. So the integrity of our legislative process is essentially to both public trust and regulatory clarity. Therefore, the Nevada State Board of Homeopathic Medical Examiners respectfully requests active participation in crafting these new regulations. Our board can supply critical expertise regarding HPUS standards and terminology to ensure that homeopathic dosing is clearly defined in any new rulemaking. For example, specifying the serial dilution and succussions as outlined by HPUS are required, and that use is limited to homeopathic forms of controlled substances or dangerous drugs. This partnership is essential to prevent misuse, preserve the intent scope of homeopathic practice, and remain within the constraints of NRS 630A.040 and NAC 630A.014, which vest the Homeopathic Board with jurisdiction over homeopathic modalities, even as we collaborate under NRS 639.233 for monitoring and enforcement. We sincerely commend the Pharmacy Board for its leadership in this initiative. The Homeopathic Board stands ready for ongoing partnership, including the development of joint guidelines that respect both NAC 630A.014F and the Pharmacy Board's oversight under NAC 639. This united approach will serve Nevadans by ensuring public safety and supporting safe, effective, integrative medicine. Thank you for your time and consideration for this matter.
Great. Thank you so much for your comments and your input. Appreciate that.
Madam President, and thank you for your comments. Dave Weiss for the record. So I want to put on the record that we do have a good working relationship with the Homeopathic Board. We never take any action without checking in with them. And this process is part of that. Is there a particular language in this that I don't think we're changing any definitions. I hear what you said. Your, I think, request is really to be more particular about it, but ours is like a broader, because we're just saying the homeopathic pharmacopoeia, but you're saying you want us to say things about dilutions. So do you have with you today any proposed changes you want the board to consider?
For now, I guess we definitely want to collaborate with you about this. When I mentioned succussion and dilutions, these are actually specifics in the HPUS that we definitely can help you with. So that's why speaking for the whole board right now is probably not something that I want to do. And as we want to conglomerate also on our end in regards to maybe, I don't know if you have a team there in your board that also will collaborate with us in relation to this.
Yeah, I mean, we do. I'm trying to figure out the best path for the board. So I think you either table it. The thing is what he said in his statement tightens up the language as opposed to, and ours is really broad. So on the surface, if they have something in their chapter that is more stringent than ours, they're still going to have to follow that particular part of the chapter. And I think by definition, as he already said, things that are in the homeopathic pharmacopoeia of the United States meet that definition. They are dilutions. And so I think the two paths are, and we do want to be collaborative. And again, this is what the process is because we noticed it and they came, which is great. I just don't know what that's going to realize. But if you want to table this and tell staff to talk to their board, staff, we can do that and then bring something back. I think at its essence, we're just doing what the AG gave us.
Right.
I don't think that, I'm getting a sense that they feel like you're stepping on their toes, which I think we need to respect, but I just don't see that knowing the language, but happy to table it, bring it back in October, and then they come to the table and say, they liked it or didn't like what we did. So, I mean, I don't see any path other than that unless you want to move forward with it.
No, I'm comfortable with tabling it, and that gives both
Absolutely.
boards the opportunity to collaborate on the matter, and then we'll see it at the future board meeting.
Yeah. But and Brett will do that, and Yen will probably help too, but we can't migrate from the opinion, so like, that's not gonna happen. So we're going to codify the opinion, but we will definitely look at these nuances that they're talking about. So I think, again, what I'm saying is, we've made it very broad. They're talking about more particular things, and I like keeping it broad, but we'll see what they have to say. And like he said, he can't speak today, so let's respect that and we'll work with them. Okay with that?
We'll table the matter to a future meeting.
Thank you, sir.
Thank you so much. Okay, with that, we're going to continue on with our agenda, and we'll go to agenda item 13, which is presentation on the 83rd session of the Nevada Legislature. I'll turn it over to Mr. Hillaby.
Thank you. Good afternoon. Nice to see you all. And as always, thank you for the privilege and opportunity to represent the board. It is something I enjoy and the firm enjoys as well. I know you're late into a 2-day meeting. I'll give you kind of a quick overview of a few highlight things during the session, some of the bills, and then get to the one subject I think probably everyone's very interested in, which was the idea of some changes to board and commission oversight. We're back sort of session 2 in the dynamic with a Republican governor and Democratic majorities in both houses of the legislature and all of the sort of extra drama that entails. I'll cut to the chase and say that it ended up with some challenges in that relationship. The governor broke his own record, he said in 2023, of 75 vetoes, this time with 87. Vetoed some of the same exact bills that were sent to him again. There's sort of no way around saying some of that is politics on both for the Democratic majorities and for the governor. It's kind of a repeat of some of the same ideas. The session ended, as John Ralston, the political sort of guru, likes to put, none of them end pretty. This one ended fairly ugly. Some high-profile bills died, including some of the governor's high priorities: crime bill, healthcare workforce bill. There was a film tax credit bill. I'll get to sort of why those things matter potentially in a little bit. I'll just go through a handful of bills and be happy to answer questions. We track a lot of bills for the board because as a state agency, all kinds of things would not affect us necessarily any differently than anyone else, other local state government agencies, regulatory boards, but watch them just so we know and the staff knows if changes that need to be made. A couple of bills, a handful that passed, AB 444 makes some changes to how business impact statements are done and regulations are adopted. So that does require a little bit of extra work. That came from, primary sponsor was the Assembly Republican Minority Leader Greg Hafen. He had some specific frustrations with a couple of local government entities that he didn't feel like were doing a very good job of reaching out to the public and understanding what they were doing. So got some new rules that everybody's following. AB 483 provides for expedited licensure or prioritization of licensure for healthcare providers in underserved areas. From a practical perspective, I think this doesn't have a lot of impact on the day-to-day operations of the board. Licensing people very quickly, as most of the healthcare licensing boards are doing. And 2, I think it's not hard if someone identifies and goes through the necessary steps as outlined in the bill to say, I'm planning to practice in one of these areas, for the staff to identify that application and move it. But again, you're not doing those slowly in any sense and at all. So I don't think that's really much of an impact on the day-to-day basis. Senator Jeff Stone, who was a pharmacist himself in his prior career before becoming a legislator, had a drug take-back box bill to sort of expand the use of those. That did successfully pass. I'll go through a handful that died. One, we saw the vetoed bill dealing with kratom from 2023 come back this session. It was not heard at all by the legislature, which is not surprising, and they did not take up any of the governor's prior vetoes. Given my opinion at the moment, given some of the national publicity on kratom and some of the other substances out there, I don't know that we'll see that come back, but I don't think that industry is gone by any means either. So something we'll watch for. AB 120 was a bill that would have required, as boards or any agency looked at regulations, if they had a total economic impact above $500,000, they could not be processed as regulations and would have to be done as a law. So that really would have impacted particularly larger boards with large number of licensees. You think about the size of our licensee base, a very small change in something in a fee that could be raised by regulation in response to the prescription monitoring program needs or fingerprint background checks, you name it, could hit that $500,000 mark and they would not be able to be done as a regulation. Dave, one of his trips to Carson City was actually there. We met with the sponsor, walked through the oversight the legislature currently has to the Legislative Commission. And that's not as familiar to all legislators because it's a subset that serves on that. So that bill did not go anywhere. And I think a lot of that was with the education effort we made on that. We had, again, another attempt to pass a medication-assisted suicide aid and dying bill. That also died. That's been contentious. It's been vetoed in the past. It's died. Nevada still has not passed a bill dealing specifically with that. While it's not a direct impact on the board, it does have an impact, obviously, on pharmacists because they're included. And the law had information about how they could choose or refuse to be involved in such a thing. Senator Stone had another bill to do licensure by endorsement. It was a noble idea, but in practice, the way it was written, it actually would have made our job and some of the other healthcare licensing boards' jobs more difficult on the way we do licensure already. So I spent a fair amount of time with him, let him know what it was going to do, what was already out there, and that he was also fine with that bill going away, which was great. So the big subject that occupied a lot of the time and attention for all of us was proposals to redo oversight and centralization of boards and commissions. At the Department of Business and Industry, you'll recall in 2023, the beginnings of that bill passed to create the office there. The primary bill was pre-introduced in skeleton form. It's not something we see a lot, but it would have an idea about what it might look like for one board in particular. And then later they would fill in the gaps for all of the other boards. And the bill at various times was rumored to likely reach 1,000 or more pages. It never got to that point. That is SB 78. We worked ahead of the session with business and industry to provide some education and some thoughts about kind of the history. For a little background, a number of us have been pushing for years for some more centralized oversight and reporting, specifically because at any given time, I don't think there are any more or fewer boards and commissions, perhaps not operating optimally than there are state agencies broadly. We do get criticized for that, and we all sort of get lumped into one thing. So for boards like the Board of Pharmacy and others that are operating at a high level, carefully making sure they're following their statutory and regulatory requirements, being responsive to their primary mission, protect the health and safety of the public and provide a fair and transparent licensing regime for licensees. It would have been a nice thing to sort of nip some of that in the bud. The proposal in SB 78 in its skeleton form that came out went far beyond any of that and really centralized a lot of functions and activities at BNI, would have moved a lot of staff over there. I think part of the consternation that sort of bled over into the legislative session as various meetings were taking place, a lot of concern, and rightly so, among board staff about how many would have jobs when this ended, how many would be offered a job at BNI and lose the job and the people in the place they're used to working, how many might not have jobs at all, and those were based on comments from BNI. I think some of that toned down a little bit. There were a couple of lengthy hearings on the bill. It really, because it was so broad and so many unanswered questions, and I think the business and industry, and they worked very hard and want to acknowledge that, the more they got into it, I think they also began to see how many questions there were out there and that the boards do operate somewhat differently. While there were some things that some commonalities across most boards or all boards in some cases, a lot of boards do operate differently. As the boards were tasked with providing a large amount of information, responses to data requests and other things, that also became pretty apparent that there was not a great understanding from people that are working in the traditional state system. I'll simplify that. Where your budget starts over July 1st, new pot of money, and here you go. It doesn't work that way with boards and commissions who get no general funds and are entirely self-reliant. And the timing on license renewals, there are boards that do biennial license renewals. So if you don't sort of look at the cash and accrual accounting information, looks like a board's losing money in a given year. They're not. If you looked at the following year, look, they were making a lot of money. So I think we saw there was still a lot of education that needed to be done there. So ultimately, SB 78 ran into a lot of problems, I think, just under its own weight. A lot of questions from legislators. Some of the presentations included information that was supposed to have come from the board and commission financial data. What ultimately was presented to the legislature was pretty far off the mark. Showed the Board of Pharmacy, among others, being in the red, which we were not, by a large amount of money. So I think that those were indications there was still a lot of work that needs to be done to make this happen. A number of us worked on behalf of a variety of the boards, and others worked with the governor's office. I had a number of meetings up through the final weekend of the session to see if there was a version of this, because again, there are some things that need to be done and some guidelines that need to be out there on a version of the bill. A couple of things happened. It became pretty clear SB 78 was not going to survive. Greg Hafen, the Assembly Minority Leader, got BNI and a smaller group of the boards together, governor's office, to see if we could come up with a sort of scaled down version. That became AB 601 the last weekend of the session, and in the last 24 hours, that was just too much. There are too many other things going on. I mentioned some of the high profile bills that died at the end of the session, not because of us, we weren't directly connected, but all of that created an environment that was going to make it hard to get things done. And the other current that was running through all of that was proposals to staff BNI. The sort of policy part were contained two different ways in SB 78 and AB 601. The actual implementation authorizing the positions appeared in SB 507, which is a bill fairly late in the session. At one point, that was as many as 55 new employees at BNI. And then there were an additional pot of, I think, 9. They started as 11, became 9 employees. That bill also died. I think there was just too much confusion at the end and concern about what this meant. So one bill has the sort of mechanism to fund 7 of those, I think 7 of the 9 or 9 of the positions. 2 of them are currently at BNI. But the actual bill authorizing those positions to be filled didn't pass, and the funding mechanism for it. So still some work to be done. The business and industry has convened a smaller group of 5 boards, sort of representative of different kinds of professions and sizes and types of boards. That was in July, I believe, did the first draft with that group of some regulations that BNI would do to try to advance the work. Those are undergoing a fair amount of work. A revised version was given to that working group about 2 weeks ago. I think they had a short meeting last week. As you know, there are other things going on in the state right now that are making meeting and getting some other things done a little more complicated. So I think there's some hope we can take that and make some meaningful progress. Again, for the vast majority of boards who are doing the right things, mindful of their obligations, having regular public meetings, conducting them as professionally as you do yours, getting licenses out the door quickly. They'd be fine if there was one centralized place. And there was sort of no question that we were, in fact, yes, here's the audit. Yes, here's the purchasing documents. Yes, here are how all of our contracts are being done correctly and moved through the system, reviewed by the AG. Our regulations are being adopted appropriately and following the Administrative Procedures Act. Again, I think most would welcome that sort of check mark at the end. So we continue to work on that. I think it's a work in progress, both the regulations, and then we'll see what potential legislation and may come out of that heading into 2027. So I'll wrap up really briefly and then be happy to answer questions about that particular subject or others. We are already seeing a lot of turnover in the legislature. We always do, between the combination of term limits and people looking at other opportunities. This is fairly early, just about 3 months after the session ended, to know as many vacancies as we're going to see. The Speaker of the Assembly, Steve Yeager, has announced he's not planning to run for re-election. The Majority Leader of the Assembly, Sandra Howdege, has announced the same. The Chair of Ways and Means in the Assembly, Danielle Monroe Moreno, has announced she is running for North Las Vegas Mayor and won't be back. Katie Kasama, one of the Republican members in the Assembly, has announced she's running for Clark County Commission. Joe Dahlia, a freshman Democratic Assembly member, has announced he's running for State Treasurer. Nicole Canizaro is running for Attorney General, the Senate Majority Leader. She is midterm because of their 4-year term. So one way or the other, she will be in Carson City, either as Attorney General or back, likely as continuing on as the Majority Leader of the Senate. Ken Gray, Assemblyman from Northern Nevada, has already resigned to take another job that was in government and federal government that required his resignation. I think more are coming. So already seeing a lot of movement, and then we'll have a number of competitive elections. As I said prior to the session and kind of giving you an overview, one of the dynamics is the governor wanting to set up a world where Democrats did not control 2/3 of either house, preferably, or at least not more than one house, specifically about veto overrides and taxes or fees, because those 2/3 votes are required. The governor and his team made some progress on that front. I think they would like to continue to do the same. Clearly, the Democratic majorities would like to gain some seats and hold on to their majorities. There are some very competitive seats. I expect competitive and probably, frankly, pretty ugly campaigns in some of those seats. So, and that acrimony ultimately carries over into every session. It's just the way of the world. So we'll see what happens there. And lastly, and because of some of those high-profile bills I mentioned that did not pass at the end of the session, we are, I think, likely to see a special session of the legislature, probably in November, is what most of us are hearing. That is likely to include the governor's crime bill. It may include film tax. There's still a lot of momentum from the advocates of that to try to get that on board. Maybe some version of the governor's healthcare bill, which included some healthcare workforce issues, potentially economic development. And there's still a lot we don't know about things happening at the federal level. We do know as a result of the budget bill, in the federal fiscal year 27 budget does anticipate some very serious cuts to Medicaid, supplemental nutrition assistance, and other programs. That doesn't kick in until October 1st, 2026. So the effect on the state budget is not happening soon. We do have about $1.3 billion in the state's rainy day fund. So I don't know if any of that would ultimately be on the special session. There's not a need to deal with it now because we don't really know what the numbers are like. The one caveat to that is a couple of weeks ago, you may have seen headlines about the SNAP program. In anticipation of those cuts, the federal government has made one cut immediately, which is states were able to use the eligibility engine from federal government for free. Federal government says you have to pay for that now. I think the Nevada cost was $224,000. Not inconsequential, but not a lot compared to the state budget. Don't know that that's going to percolate to needing to be on the special session agenda. It has something that the Senate Majority Leader, Nicole Canizaro, has publicly identified as something she would like to see discussed. I'll just offer a personal opinion. I don't think the governor probably wants this to become, that special session to become a referendum on federal budget cuts and the current administration. If it's not necessary, I think that's going to play into some of the politics. So we do expect that. We will be there, obviously, watching. Don't see anything that would directly impact us or boards and commissions more broadly at this point being talked about, but we'll be watching that. I will stop and be happy to answer questions.
Well, thank you so much for your update. Any questions for Mr. Hillaby?
I'll make a statement. I just, you know how knowledgeable Mike is. The alternative to Mike's contract that's in our best interest is to have a full-time employee or have me down there or Yen down there or Laura down there maybe sometime in the future. The value is easily seen. I think unfortunately for Mike, he doesn't get much of an off time with us because there's always something comes up and he knows what I'm talking about. And he's just a great resource and can help us get education and the things done. We don't use them really for lobbying, we use them for education. And I know for Yen and I will thank you, Mike, and I know you're going to probably thank me, but we thank you for everything that you do for us. And it's, when I have to call Mike at 8 in the morning, like this morning, or 9 o'clock at night when he's trying to drive home somewhere, I do really appreciate him. And we've had a long relationship with him and both his father, we should recognize that, and appreciate you helping us, Mike. So.
Well, thank you very much. And I do want to say, I mentioned at the beginning, it's a privilege to represent you. Part of that is because the policy setting and guidance of this board over many years and a great staff makes my job a lot easier. You are well respected in the governor's office by legislators. They know we're going to be responsive if there's a problem, if there's a question. Be it vaccinations to, you name it, let's call the pharmacy board, we'll figure out what's going on. Something has happened affecting public safety. So it's nice to know that we're a go-to resource. And again, that does make, even when Dave's calling me late at night, it does make the job easier because everybody does a very good job. So he, Yen, Dave, Greg, Brett, Greg, others are available, turn around information quickly so we can do our jobs down in Carson City. So thank you.
Great. And I'll just add shortly to that, we do really appreciate the work that you do on our behalf, and we recognize your efforts, and it was neat to kind of see it in this last session and see you in action. So really appreciate and thank you for the work that you do.
Thank you.
All right. With that, we will move on to our next agenda item. And we'll go to 6A and 6B. So if we have representatives from Advanced Prosthetics and Orthotics, if you could please come forward. Okay, we're going to move on then. And I'll call for agenda item 7A for National Health RX. If we have representatives, if you could please come forward.
I'm from Advanced Prosthetics.
Like your
Do
decision.
that one first?
Yeah, we'll do, sorry, gentlemen, we'll do the Advanced Prosthetics first since they're responded. Okay, who do we have here from Advanced Prosthetics and Orthotics?
I'm Tony Gorgon.
Okay, will anyone else be joining you, sir?
Mr. Vikram was on. He's in Florida. I am not sure if he is still on.
We're looking for him.
Yeah, he's on. Vikram, you just need to unmute your line. He is on, I don't know if he's unable to unmute his line, but he's currently muted.
Yeah, he was in a meeting conference, but he is on, but I'm not sure if he's got connection where he is in Florida.
Okay.
Do you need him to appear in front of the board today? Does he have?
I'm not sure that we do.
Okay.
Right, then we'll go ahead and proceed. If you could again state your full name for the record.
My legal name is Tunjai Gorgon, Tuncay Gorgun.
Great.
I
Thank you,
go
Mr.
by Tony, just to make it easy for everybody.
Thank you, Tony. I'm going to swear you in. If you could join me in raising your right hand. Do you swear that the testimony that you're about to provide will be both truthful and complete?
Yes, I do.
Great. I'll turn it over to Ms. Tucker.
Thank you, Madam President. This is Laura Tucker for the record. Before you is agenda item 6A, which can be found starting on page 4229 of the board book. This is an application for change of ownership, and this is for a new location for an MDEG, Advanced Prosthetics and Orthotics. This is for the Henderson location, which is the new location. And Mr. Gorgon has already introduced himself. And then I'll note also that Mr. Vikram Chowdhury is also one of the owners who filled out the application. Mr. Gorgon, so I know that this is an existing business and Mr. Chowdhury has purchased the business, and you plan on continuing to sell prosthetics and orthotics.
Correct.
And also that Mr. Chowdhury has a number of other locations in other cities in the country. Can you just very briefly describe the business?
The business of orthotics and prosthetics is, I want to make this comment because I have been on the board meeting since 9 o'clock this morning, and everything is pharmacy focused. So orthotics and prosthetics that we do is 180 degrees from what I have heard so far. And if I may, the first time I've been practicing in Las Vegas with 3 locations since '96, and first time I was encountered with Board of Pharmacy licensing is 2004. I may be off a year or two, but it was then. So before then, we were not licensed by State Board of Pharmacy. So we're regulated by Medicare, and we're regulated by American Board in Certification and Accreditation in Orthotics and Prosthetics. So I would like to extend this to the board, if you will, please, to look at the orthotics and prosthetics and see how we differ. And I'm happy to discuss this later after this meeting if desired. And don't put us in the same category as the pharmacy, because many things that are brought up to my attention over the years that I met with many.
Mr. Gorgon?
Yes.
Thank you for sharing your thoughts on that. And I think that's something we could discuss at a later time. And then what I'd like to do is to bring it back to your application in front of us.
Okay.
So, yeah, we have noted what you have said, but I'd like to focus on your application for today.
Okay, so orthotics and prosthetics is custom in nature in most part. Everything we do is custom made, custom fit, including a simple wrist brace. And that's what differs us from other durable medical equipment. We operate our own laboratories, and we see patients by prescription only, prescribed by qualified MPI carrying physicians, nurse practitioners, PAs, and we only see them with that referral. And the uniqueness of what we do is the 180 degrees that I have mentioned. So I'm not sure what else you're asking me to describe in what we do and how we do it.
Thanks. That is a great description, Mr. Gorgon. And just to confirm, medical devices are considered drugs under Nevada law, and so therefore they are regulated by the Board of Pharmacy. So that's why you're here in front of us today, because this is for an MDEG license. Just to confirm, so you own one other MDEG location in the state?
There were 3 locations. We just closed our Prompt location, and we are opening one in Henderson, but we have operated in Henderson in a different location since 2000. And we closed that and we moved it to a different location, and that is one of the licenses that is in front of you. So it is actually a replacement of the office that you had licensed in the past.
Okay, great. Thank you. And to confirm, you're going to be selling directly to patients. Is that correct?
Correct. We are a clinic. We're not a store. We see the patients and we customize everything we do to the patient.
Great. And then, so I'll note for the board that we also have the application from MDEG administrator. That's Nathan Gorgon. His application is found on page 4244 of the board book. I'm not sure, Mr. Gorgon, if you could tell us, I had a couple of questions for Mr. Nathan Gorgon. And I guess he's not available for today. But I see he's been with the company since January 2008. Is that correct?
Correct.
And in his role with the company, or actually, can you tell me what his role with the company has been since 2008?
He's been an administrator, managing the Henderson office in most part. He's also an IT tech.
Okay, so he was already the existing MDEG administrator, is that correct?
Correct.
Okay. So in that role, he was already familiar with the products, and
Yes,
also, yes, and also with fitting the product and repairing the product as well.
No, he doesn't fit the products, and that's one point that I wanted to make that you asked me to address that at a later time. But Again, you're asking our practitioners to be present in our offices. Our practitioners are not pharmacists. They don't need to be in that office every single time that a patient needs to be seen. We go to that office when we are need to. So we hold a clinic. So the way you're describing how we have to be present as a practitioner in that office doesn't fit our operation. And that's what I was trying to bring up to you.
Yeah, Madam President, Dave Weisberg. I mean, if we don't have the right people here, then we probably need to table it, and they're still operating, so they're operating right now while they're waiting on the chow, and staff can work in the meantime, or we can try to find the person that needs to be able to answer the questions.
I think there's, I'm not sure there's we're on the same page with Mr. Gorgon's interpretation of the laws that are part of the issue.
Yeah. And staff can work in the meantime to do that. Again, they have they're operating right now.
We have practitioners in each office that are board certified orthotists and prosthetists. So I'm not sure what you're asking me when you say administrator. Is that what you're asking me, if Nathan is the administrator there?
Well, it looks like he is the MDEC administrator according to the application. Is that incorrect? He is not the MDEC administrator?
Yeah, he is, but I have brought this up several times in the past, and the last time we discussed this was with Larry Pinson, who was the executive secretary in 2012. And I was asked by the inspector then that I needed to be present because I was named the administrator in our prompt office. And I needed to be there from 8 to 5. And we discussed this with Mr. Pinson then and agreed that we are not pharmacists, and our services, our patients don't need a practitioner sitting and waiting for them. And so therefore it was addressed and agreed that an administrator who is familiar with the practice for so many hours can be named as the administrator, and it doesn't have to be a practitioner. So Nathan Gorgon, in that context, has years of knowledge of the practice and patient care, not necessarily caring for the patient directly himself.
That is fine too, as long as Nathan Gorgon meets the requirements of an MDEC administrator. He doesn't have to be a practitioner seeing the patient, but if he meets the other requirements of the MDEC administrator, he can be the MDEC administrator.
He does. He's been employed and managed the practice for many years.
Okay, I had a couple of questions for Mr. Gorgon, and I'm not sure that
Yeah, since if
he's
not
here.
if you have questions for Nathan Gorgon,
Then
he's
we
not
can't
here,
move
then we
forward.
can. Yeah.
Cannot move forward.
So then, yeah,
And we can give him some time to find him and maybe get him back at the end of the meeting. But if you have questions, can you go, if we put you on pause, can you go find Nathan and get him on the line?
Well, Nathan is currently in the Henderson office, and I didn't realize that he needed to be on this meeting.
That's fine.
We
Can you get
can
him?
call him and bring him on if you like.
Okay, we'll do that.
That, or if you want, we could put you on the next meeting agenda potentially. Do you want to move it to, since you're operating, do you want to move to the October agenda?
So let me ask you this, if I may. What if we changed the administrative role to me? I'm the administrator.
Today's not the day to do that. So if you want to do that, you'd have to table it, and we could do that in October. And that's a possibility to go down that path. Staff will help you with that. It probably will not work, but we can help you with that because you're already an administrator somewhere else, I think. So the direct question is, do you want to go on pause to try to track down Nathan and have the possibility of coming back with the board meeting's going to end at 2:30? Or do you want to table it till October and have more time?
Let's delay and get Nathan on board
Okay.
because we do need
We,
this.
we will make an attempt to get back to you.
Okay, I'll bring Nathan on board and we will wait for you to call us back again. I
Madam
will
President.
stay on and I will bring Nathan on board.
Okay, sounds good. Madam President, just so you know what's in front, we have two individuals, 11A and 11B, that their livelihood depends on being able to see you today. So I would probably tell you, I know we're not going to make it, but I would go to them so that if you approve them, they can get to work.
Okay, all right. We will go to 11A for Eric Disbrow. We have Dr. Disbrow present. If you could please come forward or raise your hand on Zoom. Hi. Have a seat. All right, if you could state your full name for the record.
Yeah, Eric C. Disbrow.
I'm going to swear you in if you join me in raising your right hand. Do you swear that the testimony that you're about to provide will be both truthful and complete?
Yes.
Thank you. Okay, Ms. Tucker.
Thank you, Madam President. Again, this is Laura Tucker for the record. Before you is agenda item 11A, which can be found starting on page 4954 of the board book. This is a controlled substances application from Dr. Eric Disbrow. And Dr. Disbrow, I'm just going to go over your application with the board and they might have a couple of questions for you. So it says on your application that you're going to be practicing at the Student Outreach Clinic here in Reno. And can you explain why you're looking to obtain your controlled substances license today?
Well, that's a voluntary position. I have no use for the DEA number there. But not knowing what the future might bring, I'm continuing my DEA license, which I've had since 1972. And it's currently approved till 2028.
Okay, great.
This came to your attention because I don't practice in California any longer. I'm trying to get an address in Nevada at the social clinic so I can keep that license in case I need it in the future.
Okay, and you did have a disclosure on your application. I'm just gonna ask you a couple of questions about that and just confirm some information. So you stated on your application that you stipulated with the California Medical Board to resolve an action that originally was charged as inappropriate prescribing, but later was amended to poor record keeping. So that was what the settlement was stated. Is that correct? And you settled this with the California Medical Board in March 2022, correct? And the result of that is that you had no restrictions on your California medical license. Is that correct?
Restriction on a DEA license. And I got 2 licenses since then in Nevada. They're good till 2027, so.
So, so as you stated, your Nevada license was issued through the Board of Medical Examiners in 2023 for Nevada, correct? And again, you said you currently have your DEA license. And then do you have any conditions on your Nevada medical license or your DEA license? Okay. And then have you made any changes to your practice since your settlement with the California Medical Board?
Since the settlement, I got served the week before I retired and moved to Reno. That was in 2021.
Okay. All right. I don't have any other questions. If I'd like to submit this to the board for discussion.
I appreciate that. I don't have any additional questions either. I think Dr. Disbrow answered the questions that we had, and seeing that he has no restrictions on any of his licenses, I would feel comfortable moving forward with this application today.
I would agree. Adam Porth for the record. I would move that we approve controlled substance application for Eric Disbrow.
Crystal Freitas, second. Okay, we have a motion by Mr. Porath, second by Ms. Freitas. Any further discussion? Okay, all those in favor?
Aye.
Any opposed? Okay, that motion passes. All right, we thank you for your time today, Dr. Disbrow. We wish you all the best. Okay, next I'll call for agenda item 11B for Dr. Jeffrey Backofen. If Dr. Backofen is on the line or in the room, if you please come forward.
Dr. Backoffen, present.
Hi, good afternoon.
Hello.
I'm gonna, if you could state your full name for the record.
My name is Jeffrey Backoffen.
Okay, Backofen. I want to say Baclofen so bad.
Everybody wants to say Baclofen.
I know.
We'll try
I
my
get that a
best.
lot.
Poor guy.
For pharmacists here. All right, so I'm gonna swear you in. If you could join me in raising your right hand. Do you swear that the testimony that you're about to provide will be both truthful and complete?
I swear.
Great, thank you so much. All right, I'll turn it over to Dr. Long.
Thank you, Madam President. Yan Long for the record. Dr. Backofen or Backofen. Ms. Yan Long, I've been communicating with you regarding your application. So I'm going to present to the board your application and I have some questions for you. And the board may also have some questions, okay? So please feel free to correct me if I'm wrong, but I'll have you elaborate on some of the things that we found in your application. So Dr. Backoffen's application begins on page 4993 of your board book. He is applying for a controlled substance registration with the board and is appearing before you today because in reviewing and processing Dr. Backoffen's application, board staff discovered some information that was not required to be reported by Dr. Backoffen on his application because the questions don't ask for it, but it is information that the board discovered. And we have other resources that we utilize when we process and approve applications. And this information we felt was important for the board to consider before approving his application. And the information that was discovered was that Dr. Backoffen's clinical privileges were summarily suspended November of 2023 by the Shaw Air Force Base in South Carolina, pending completion of due process proceedings due to concerns of wrongful use of controlled substances that adversely affects or could adversely affect the health or welfare of a patient or staff member. And then on February 26th of 2025 this year, Shaw Air Force Base determined that revocation of Dr. Backoffen's clinical privileges was appropriate. He was discharged honorably. So that was information that wasn't required of Dr. Backoffen to report to the Board of Pharmacy, but we did discover that. So he is here before you today to discuss that with the board. So Dr. Backoffen.
Yeah, can I make one point? Sorry.
Yes.
It's not through the fingerprint process. So there was no, this isn't fingerprint data that you're sensitive and all that. So this was a public record. So just say thanks.
Yeah, no, certainly. Dr. Backoffen, can you explain us what happened in November 2023 that led to the summary suspension? And then what has occurred since then?
Yes, as I've already kind of communicated with you, at that time I had gone up to Wright-Patt Air Force Base in Ohio and undergone some centrifuge training where I had to sustain 9 Gs for 30 seconds, which of course at my height did not do any favors for my lower back. At that time, I was also moving into my house in South Carolina, and during that time I took the last 3 of my own personally prescribed Norco that I had had from an old nose surgery a few years beforehand that had just been stored in my fridge for the back pain as I was moving in. And then, as I had mentioned in our emails during that time, unfortunately, as I had mentioned, came across some loose leaf tea that we had been given that turned out to have been coca leaf tea. And when I was hit for my random by the military, obviously those came up as positives. Since that time, immediately after that, just to make sure that there were no concerns as far as patient safety wise, I did go and do a 4-week inpatient treatment program down in Florida, after which I came back to South Carolina, did 6 weeks of the intensive outpatient therapy through Three Rivers Behavioral Health, and then participated in and completed the Air Force's ADAPT alcohol drug abuse prevention treatment program as well during my time in the military. And throughout the duration of that time, I was also being monitored by the South Carolina PHP program from the start of that 4-week inpatient program up until I moved back to Nevada in December of 2024, when I began moving my monitoring over to the Nevada PHP program, through which I'm now being monitored by Mark Chase.
And Dr. Backoffen, do you have a drug or alcohol problem, or did you enroll in these programs just to show that you don't have this problem?
I do not have a drug and alcohol problem. I made sure to enroll in all these programs just to be very clear that this was not an ongoing issue. This was a one-time issue, lapse in judgment, and that this was not an ongoing problem.
Perfect. And you did submit that you do have a contract with Mark Chase with Nevada Professionals Health Programs Medical Counseling. And that contract's from June 7, 2025 to December 31st, 2026. And in that contract, it looks like you will be doing random drug testing, including attending meetings as well. Is that correct?
That is correct. I do attend a weekly Caduceus meeting with Dr. Chase. And then I also speak with him weekly, one-to-one, just to have my two meetings as well.
And it looks like you will be working for Valley Medical Center. Is that correct?
That is correct. I am an intern resident with the Valley Hospital Family Medicine Program.
Perfect. I don't have any further questions, Madam President. That was just the only thing that came up of concern. I don't think that he has any drug-related issues, but I did want to bring it up because it was related to drugs that he was discharged or had his clinical privileges revoked. I'll turn over to the board for further questions.
So I just, this is Helen Park, just wanted to clarify. So currently at this time, there are no restrictions on your medical license here in Nevada or any other state, is that correct?
That is correct. There were never any restrictions placed on my license in South Carolina prior to my discharge because I did self-report to the board and self-reported to the South Carolina PHP program. So there were never any restrictions placed on my license there. And that transferred across to Nevada. The one addition the Nevada State DO board did add was that they just wanted an additional year of monitoring over what South Carolina had, which would have ended this November. Nevada just wanted one additional year just to be sure. Otherwise, there was no restrictions.
Just for but that, they put that on, they ordered that for you. So that's a requirement.
Yes, that is correct.
Okay, just for the record.
Okay, any other requirements out there on your license?
Nope, that was it. Just to extend the monitoring contract with the Nevada PHP for an additional year. Otherwise, there's no restriction of any kind on my license.
Great. And then in the past, it sounds like it was the random drug screen and there was no patient harm, or it wasn't related to your patient care practice.
That is correct. I actually hadn't even been privileged at the time. I didn't actually get my privileges weren't granted until about 2 weeks after that incident. But it took about a month and a half for them to verify the results of their tests. So I had the privileges for about 3 to 4 weeks before they then turned around and suspended them for the test. Yes.
Okay, great. Thank you. I don't have any further questions. Any other questions, board members?
Dr. Backfin, you indicated that on your application that you wanted to include Schedule I substances. I'm assuming that was not accurate.
Yes, that was probably
So I would be comfortable making a motion to approve the controlled substance application for Schedules 2 through 5 for Dr. Jeff Backfin. I'd like any reporting that the DO board is getting for the remainder of his.
That'll help you. I think we have a pretty standard.
Chase.
Yeah,
We would get those reports as well.
Yeah, we'll mirror what the DO board has done, and any reports that is getting received by the DO board will also get it at the Board of Pharmacy. So we'll contact Mark Chase to make sure he does submit those to us as well.
So just to be clear, that'll be a condition of your controlled substance license.
Yes. All right, so we have a motion. Do we have a second?
Crystal Freitas, second.
A motion by Mr. Porath, a second by Ms. Freitas. Any further discussion? Okay, all those in favor?
Aye.
Any opposed? That motion passes. All right, we thank you for your time, Dr. Backfin, and we wish you all the best.
Thank you very much for your time as well.
All right, we will go to agenda item 7A for National Health RX. Please come forward. Hi, good afternoon. Okay, if I could have each of you state your full name and titles for the record.
Good afternoon, Joey Gilbert for the record, attorney for National Health Alliance and Massimo Cavalier, Swansea. Good afternoon, President Barber, members of the board, obviously, Mr. Weiss, staff and council.
Thank you. All right, if I could have the other two gentlemen state their full names for the record, please.
Name is Massimo Cavalier.
Thank you.
And Joe Willis.
And I'm going to swear both of you in together. Just need a verbal affirmation from each. Do you swear that the testimony that you're about to provide will be both truthful and complete?
Yes, thank you.
Great, thank you. All right, I'll turn it over to Mr. Weiss.
No, Zinniano is going to support me. Mr. Cavallero, I think I know who you are, but I don't know who the other person is. So what's the purpose for your appearance today? Yeah.
Lewis.
This is Mr. Joe Lewis. He was my compliance and regulatory officer when I had professional RX.
Okay.
I'm retaining him now. For my.
He's going to support the operation.
If I made to the board, I kind of did, my attorney brought up to me some concerns that the board had. And I kind of got an opening statement that I think will address the concerns. I'm allowed to give my opening
Mr. President. But before we get to that point, I just want to say what we're here for. So
Sure, yeah.
okay, we'll give it, there'll be plenty of time for you to speak. In front of your board, and it starts on page 43225, is a change of ownership. The previous pharmacy was called Partel Pharmacy. You, through a different order, had required the ownership change by the end of the year. And now these people have completed the application for the ownership change. So in front of you, you have a request for ownership change. And with that, because we're short on time, I'll turn it to you.
Thank you. I'll try to make this quick. In early 2014, I assisted a longtime friend and practicing attorney in launching his first pharmacy in Las Vegas. My background was in corporate management and operations. Having served as director of operations for Xerox and several medical device companies, including Kyphon Electronic, he asked me for my expertise to establish structure management guideline for his new pharmacy. My responsibilities included developing employee management framework, overseeing clean room design. That hands-on experience introduced me to a highly regulated pharmacy industry. 2015, following the successful operation of his pharmacy, I began discussions with him to launch a second pharmacy, this time with myself as principal owner. We formed a strategic partnership where I would oversee daily management operations while he provided legal and regulatory guidance to navigate this process. He reintroduced me to Mr. Matthew Peters, who had served as consultant for his pharmacy. On my attorney's recommendation, Mr. Peters was retained strictly as an advisory role for the application setup, compliance matter, and advisory support. His prior experience had been successful in site selection and state licensing requirements for the Nevada Board of Pharmacy and DA licensing. All interactions with Mr. Peters and any other consultant, contractors, vendors were vetted and approved by my attorney as mandatory safeguard to mitigate the pharmacy and my liability exposure. I fully adhere to this protocol. In July 2016, after a successful review and inspection of the Nevada Board of Pharmacy granted my license for professional RX. I launched and managed pharmacy, expanding operations, maintaining strict compliance. 2019, Walgreens acquired professional RX following an extensive due diligence audit confirming zero deficiencies, violations, or regulatory concerns, validating our team's strict adherence to the compliance protocol. In 2020, during the COVID-19 pandemic, I assisted a friend in a multi-state COVID-19 operation. Once demand subsided, I returned to explore opportunities to return to pharmacy ownership. In 2023, I identified Partel Pharmacy, a longstanding Las Vegas pharmacy operating since 1991, experiencing operational challenges. I reached out to owner Mr. Robert Seek for an acquisition of majority ownership. But the initial terms were not feasible, and third, I then engaged First Choice Business Broker, a local pharmacy acquisition realtor in Las Vegas, to explore other opportunities. In 2024, I reviewed a closed retail pharmacy with board-approved compounding lab and an active license, despite executing an NDA and other buyer circumvented me and made a direct offer. I also pursued two additional options, a hospital-based pharmacy, which was unsuitable for my plans, and a closed pharmacy healthcare site, which after due diligence showed inactive licenses and consistency, leading me to terminate negotiation. During this time, I became aware of disciplinary action from the Board of Pharmacy against Mr. Seek and Partel Pharmacy. With this information, I re-engaged Mr. Seek with my attorney and realtors leading negotiations. We successfully executed an asset purchase agreement for Partel Pharmacy. My compliance team submitted a Board of Application licensing for ownership transfer with a planned renaming to National Health RX, designed for transition within a 30 to 90-day licensing approval period. Following the extensive internal compliance review, asset evaluation, and BPP inspection, my team and I gained a comprehensive understanding of the regulatory issues under the prior management. My objective is to transform Partel Pharmacy into a fully compliant, patient-centered healthcare provider under the National Health RX. I'll read you my mission statement, which is the heart of what I believe the pharmacy needs to be. National Health RX, our mission is to deliver exceptional pharmaceutical care that upholds the highest standards of regulatory compliance, priorities, patient health and well-being, and fostering trust with our community. We are committed to, first and foremost, regulatory compliance, operating with integrity, strict adherence to all federal, state, and board pharmacy regulations to ensure safe, ethical, and transparent pharmacy practices, patient health and well-being, customer service excellence, employee development, operational excellence, community awareness and engagement. And National Health RX, we believe that compliance, care, community are the pillars of the pharmacy, and patients who trust us today and for the generation to come. In conclusion, my team and I are fully committed and have been proactively engaged throughout this process to align National Health RX operations with the expectations of the Nevada State Board of Pharmacy and fostering a business environment that prioritizes patient safety, regulatory compliance, professional integrity, most of all, transparency. With that, I'd like to introduce my team. That's Pam Kennedy is my human resource and compliance specialist. Being the fact that I'm taking over a pharmacy that has 30 more employees, I want a human resource administrator with me through the entire staff. I want to provide that ability for any and all employees for any issues that they have. I'm a firm believer in chain of command, but human resource needs to step in. She's always available, as I am. I operate an old school management, open door policy. Next, I'd like to introduce Joe Lewis, my independent auditor investigator of the regulatory officer. Again, he helped me through professional RX in the very beginning. I was very strong on compliance, and he got me through all the regulatory issues. Listened to exactly what it was I wanted. I understood that the buck stops with me. Anything goes wrong, I'm the one ultimately responsible, along with my pharmacist in charge. And as that, I have a responsibility to my staff, to the pharmacy, the well-being of the patients. And I was lucky enough to find Mr. Lewis for that. Next, I will have Jerry Deppa, pharmacist in charge, who's now currently at Partel. And then Mitchell Whitaker, pharmacy manager. And Joey, my turn. That I've opened to questions from, actually, I'd like Mr. Lewis to make a few statements regarding.
Yeah. Let me first introduce myself. I'm the retired chief investigator for the Texas State Board of Pharmacy. After leaving the State Board of Pharmacy, I went to Parkland Hospital as the drug diversion control officer. I set up the diversion program at Parkland Hospital. During that tenure, and by the way, I've been a police officer for 52 years, and I'm still a police officer. So at my tenure at Parkland, and then through investigations, I was assigned to the pharmacy. I was also assigned to the police department. I did arrest the chief anesthesiologist for stealing drugs during surgery. I arrested 17 nurses for diverted drugs. I arrested one pharmacist, 12 technicians and the technician's husband who planned on stealing from Parkland. Mr. I always call him Massimo, contacted me to set and prepare SOP for National Health RX. In those SOPs, I made one because today we're in an environment where we're gonna have an active shooter. So we actually have an active shooter policy, which I would also like to share with this board, to give you copies, to give to pharmacies if they want to write a guideline for an active shooter policy for their pharmacy. I just went through an active shooter training, which I black and blue all over because I was dumb enough to be the dummy. So this is my background. And then the second part of the SOPs, since we, National Health, will hold multiple licenses, we prepared an SOP for each state license. And that is in progress at this time. So if you have any questions, I'll be more than happy to answer.
Binder that has the appendix for, has a mission statement, the National Health RX, all the appendix for the SOPs, and then also the state, along with the rebranding, picture of National RX on the building, if I may pass this along.
Of course you can.
Certainly.
Thank you. And my objective as management and all the companies I've run, I like to be proactive. When I engage and start a company or take one over, I go in with a firm game plan. On day one, we're ready to operate. I'm not one to step in and go, well, let's think about this and what about that. I want to come in with a game plan. Similar to what sports team do. You don't approach another team, show up on game day and go, okay, we're here, let's go. Get that game. Thank you.
All right, I think Ms. Weiss has a couple questions lined up for you, so we'll go ahead and go to those questions. And thank you for the information provided in the binder.
Madam President Dave Weiss for the record. I can assure you that I have more than 15 minutes worth of questioning for this applicant. So I'm happy to begin that. I know that, it's no fault of you, but the meeting has to end because people have hard deadlines for travel. So if you want me to start, if you want to table till the next one and try to get the person that you already started before, it's your choice, but I will not be done in time to be at the end of this meeting. So I just want to lay that out to you so that you can make an appropriate decision.
So I apologize to everyone who has noticed today that we may not get to. I think these things tend to happen. If there are more than 15 minutes worth of questions, I don't know if it makes sense to begin those only to stop those at this point. I think you've given us some information that we can begin digesting. And I think it might be in your best interest to continue at our next meeting where we don't feel so rushed to go through your application. So I would ask that you would table your application at this time.
You don't have to agree to that, but then the board will do a ruling.
Yes, I agree.
Appreciate your understanding on that, and then we'll see you at the next board meeting.
Thank you.
Thank you.
If you want to get back to advance, then we might be able to finish that one up.
Right, so if we have representatives from Advanced Prosthetics, if you could please come back on the line. Okay, who do we have online for Advanced Prosthetics?
Hello, this is Nathan Gorgon. I'm the supervisor here at our Henderson location in Nevada.
Okay, and then we're
Gorgon.
Okay, Tony Gorgon again, and
Vikram Chaudhary.
okay, so Mr. Tony Gorgon, you're already sworn in, so you don't have to swear in again. You're currently sworn in, but for Nathan Gorgon and Mr. Vikram, you join me in raising your right hands. Do you swear that the testimony that you're about to provide will be both truthful and complete?
I do.
Okay, great, thank you. All right, I'll turn it back to Ms. Tucker.
Thank you, Madam President. Again, this is Laura Tucker for the record. I have a couple of questions, Mr. Nathan Gorgon, for you on your application for MDEC Administrator. I wanted to clarify something on page, for the board, it's page 4246 of the board book. But Mr. Gorgon, it states on there that you are currently the office administrator, inventory intake admin and technician. Are you currently the MDEC administrator for this location?
Yes.
Okay. Okay, that was a little unclear on your application.
Okay, sorry.
I thought you were applying for a new role because this is office administrator. So I just want to confirm, so you have 1,500 hours of verifiable work experience relating to the products provided by the MDEC. Is that correct? And are you going to be employed by the business at least 40 hours a week?
Correct.
Okay. And then I want to, so how long have you been the MDEC administrator for this location? When did that?
We just moved into this office, still in the process of getting things going. So it is still fairly new for me. It probably 3 months, I'd say technically.
Okay, and then, so were you on a previous application? Were you already registered as the MDEC administrator with our board through the license?
The previous license, yes.
Okay. But to confirm, you've been MDEC administrator for 3 months.
This office, yes.
Okay. Wait, so you were MDEC administrator at a previous office?
We had a former location here in Henderson as well that we closed down about 2 years ago. And I was in the process, I believe, of becoming that administrator. And I was taking over those duties.
Okay. Sorry, I'm just trying to clear this up a little bit. So.
Sorry, this is a little new for me.
Okay. So you have been MDEC administrator with the company for 3 months, but were you registered with our board with your license as the MDEC administrator?
I'm not entirely sure. I genuinely am unsure.
Okay.
Prior, it was 6 years. Because I've been with the company since 2008. It was originally a family-owned business by my father, Tony. And now we are with Vikram Chowdhury as the current owner of the business.
Okay, so for the 6 years previous, what was your role with the company?
I did administrative clerical work. I managed inventory intake as well as parts ordering, parts management for both orthopedics and prosthetic goods.
Okay, and then during your employment for the last 6 years, were you able to familiarize yourself with the products?
Yes.
Are you familiar with fitting the product or repairing the product?
Yes. I've had a lot of time working in our lab, as well as doing some fabrication, modification of braces and custom-made prosthetics.
Okay. So I think that what this is that we are going to have this be a new MDEC administrator application, it sounds like, I think.
Yes.
Okay. And then just to provide a little bit of background to the board, this change of ownership application is actually in front of us because during an inspection, one of our inspectors found that they had not informed us of the change of ownership that actually happened last October. So this is here to rectify that they should have the violation that they should have told us about the change of ownership last year.
So for that, we had gotten a citation, which we fulfilled. We explained the process. We had sent a notification of change of ownership. We should have done the application per se at that time. But being from out of state, I wasn't aware of that. And but we paid the fines and we got the satisfaction of the corrector plan. So that's where we were at.
Yes.
So this is Helen Parks. So Mr. Chowdhury, would you mind just briefly walking us through the ownership change and how that's impacted or changed the business, if it has at all, or any changes to policies or procedures or anything of that nature?
So the company which has acquired Advanced is called Quantum Clinics, which is a holding company. So which we don't have any change imposed on the actual working of the field in prosthetics orthotics and the way Advanced operates. So everything stays the same. It's just, it is owned by a holding company called Quantum Clinics now. And we have other couple practices in Chicago and Illinois area.
And then, Mr. Chowdhury, just to confirm, are you going to be like keeping all the same staff?
Everything is the same. Nothing has changed. Same tax ID, same NPI, same P10, same numbers. Everything is same.
Okay, so this is just strictly a change of ownership. Everything else will remain the same
Everything.
besides the location change.
Yes, just for the Henderson office, we're changing the location.
Okay. Okay, I think that was all of my questions, so I will submit it to the board for discussion or further questions.
Sure.
Do we need a new application at all for the MDEC administrator, or are we?
I believe it would be a new,
We did already submit the application though. I'm not sure.
So
Dave Weeks for the record.
Nathan was listed in Old Henderson office as administrator. So what he's telling you is that for this new one, a new application was put in with his name, but he administered the Henderson office for years.
Laura, do you have it in front of you?
I think there's a confusion
You
in
just read-
questioning.
Read for the record who's on it so that we,
So
and
on
that direct
page
us to do.
on page 42, 44 of the board book, yeah, Nathan Gorgon is listed as the MDEC administrator. And the confusion is that on page 42, 46, where the work history is, it says office administrator, orthotic fitter, inventory intake admin. And I think that's where at least I was confused about the role, that it didn't say MDEC administrator.
I think so too, yeah. He has the experience, but not as named MDEX.
So it's a decision for you, Madam President, however you want to proceed. If you want us to tidy it up on the back end and you have enough information to move forward, we can do that. I mean, it is a little confusing, so I'm slightly confused. If you want to have it in front of you, that would be very fair.
Sorry, Joe Dash for the record. On page 42, 49, it does list Nathan Gorgon, where he signed that he has the appropriate verifiable work experience. Just so you have that part.
Thank you. So I think I would feel comfortable with it being clarified on the back end. I think the application itself is a little confusing, but in his testimony today, Nathan Gorgon did tell us about his experience, and it sounds like he does qualify as an MDEC administrator. I think it's a little confusing with the change of the Henderson location, so I think that probably needs to be cleaned up in the application process too, because they moved. And so there's a location change unless that's already happened, or is that?
That's on this one too.
Okay. So those were the 2 points that I was a little bit unsure or unclear about.
Mark Cedar is listening and he will address that and get it back to Yen and I, and Laura can participate in that. And I think Joe knows what's going on too. So if there's any questions whatsoever, we'll bring it back in front of you.
Okay, great. So with that,
I'm happy to make.
Yeah.
Yeah. So I would move that we approve the ownership change in and the new address of the Henderson location for Advanced Prosthetics and Orthotics, as well as the ownership change for Advanced Prosthetics and Orthotics at the Las Vegas location.
Thank you.
Second.
Okay, we have a motion by Mr. Porath, a second by Ms. Carr. Any further discussion? Okay, all those in favor?
Aye.
Any opposed? Okay, that motion passes. Your application has been approved today. We thank you for your time and testimony.
Thank you.
Thank
Thank
you
you
so
very
much.
much.
Thank you so
Thank
much.
you. All right, as our final.
Oh, I
order-
have one before you do that, sorry, Madam President.
Because they don't seem.
There are, for the contact for the state, there are some agencies that are still functioning, one of which is, Brad, can you hold on for a second? And so I can tell you for the future meeting, when you get to that point, it will either the notice, which the list of people that are on our list to notify, we will notify them. It'll either be back at our website if it's functioning, or Yen and I, in the past 2 days, have been working on migrating this similar data over to the Office of Emergency Management that has a website that's going to be hosting all kinds of meetings. And you guys commend you for having a meeting when there weren't very many meetings going on. So appreciate that. But in future, I just want to read into the record that it'll be at the Office of Emergency Management as it sits today, and that's www.oem.gov/public-meetings. That'll get you to the website, and then you can track what meetings we're having. You're going to mention our next meeting, but I just wanted to tell the public that right now, that's where we would post the next meeting. We plan on having the next meeting and it would be posted there.
Is that something you could put in the chat, the website?
We can definitely put it on the chat. And so I'll pass it to Yen and she'll put that link into the chat.
I do want to thank our board staff for making this meeting possible under all the circumstances that we've had. I think it's been very difficult for any of the state boards to proceed, but our board was able to, and
Easy peasy.
we didn't get through everyone. I think we've got through a significant amount, and proud of what we're able to.
Well, and that was my point. I know we're wrapping up, but like you were able to process the people that were waiting on their license. You did have the meeting and you did get them their license. And it's really unfortunate when we have an agenda, we don't get to it all. But you got to a lot of things and you got the safety for public and all the other things. So I commend you. I know you're sad when you don't get through the agenda, but you did a great job and you don't have a control of this timing. So the timing is what it is. So Yen will post that in the chat. We'll email it out. Our website might be back up and operating, but we're the state is still doing business and that's where it'll be housed in the meantime.
Very good.
I've provided it. I just don't know when it'll be posted. But everything will go there if it doesn't go to our website.
Anything else before we go to public comment?
For our staff.
All right, so as our final order of business, the board will open up the floor for any public comment. If there's anyone in the room or online who wishes to make public comment, please come forward or let us know through the Zoom hand raise function or chat function. Okay, I don't see anyone in the room coming forward for public comment. Do we have anyone online?
Madam President.
Okay, so with that, I just want to say our next date and location of our board meeting will be on October 15 and 16, and it will be held in Las Vegas. Thank you, everyone, very much. And with that, our meeting is now adjourned.
So, you may have already.